मुझे लगता है अभी कुछ और करें, स्टार्ट नहीं हुआ है।
40 मिनट स्टार्ट हो तो रहा था।
Namaskaram everyone and welcome to today's IAP Twin Cities branch symposium. At the outset, let me thank you all for your wonderful participation in all the academic activities of IAP Twin Cities branch. We've been able to conduct these monthly symposium, PG clinics, the monthly clinical meeting, and of course your support for the central IAP workshops, including the Central Zone Pedicon. Thank you, and we are immensely grateful for your active participation. All the sessions are live on YouTube and also available for later viewing as well. Thank you, and please like, share, and subscribe to our YouTube channel, which has got all the sessions over the past 2 years. And I'm hoping that it will be useful for all of us at various points of our professional career. We request your support for the upcoming academic programs. We have an NRP TOT coming up shortly, along with the Central IAP workshops. Seek your support and active participation in these workshops as well. Today's session is on developmental pediatrics, and this is, I would say, an upcoming pandemic. The reason being that we are seeing so many cases with issues related to developmental pediatrics, and like COVID, there's a lot of uncertainty in our minds about how to approach this. Lot of disorders for which we probably know a little and lots more that we have to understand so that we can offer the best care for the patients who come to us. And we have a very distinguished team of experts who will take us through today's session. I'll now request our president, Dr. Sungoj Bhaskar sir, to please give his inaugural remarks. Over to you, Bhaskar sir.
Yeah, thank you, Dr. RSV. Thank you very much. And it's an auspicious day for me because I'm seeing legends participating in this symposium as faculty members. And as we all know, our developmental pediatrics, or you may say developmental behavioral pediatrics, is being neglected by the government, by the NGOs, by even healthcare professionals. But the scenario is changing now. There is an increased awareness among the healthcare professionals. Thanks to IAP for creating awareness and stimulating the pediatricians, and as well Government of India. I'm so fortunate to have legends today. My special thanks at the outset goes to Dr. Suchit Tamboli. The day when I decided to have this symposia with my EB members, first call went to Dr. Suchit Tamboli because I know him since last 4 years, if I remember correctly. We had one developmental pediatrics session on cradle to crayons, wherein he was an active senior participant. So thank you, Dr. Sujitji. Despite being in Thailand recently, coming back with your background, I think it's a Phuket sea shores. Thank you very much. And Dr. Samir Bhai, despite his busy schedules, he found time to be among with us. That shows his interest to the developmental behavioral pediatrics and is as well, I think, towards IAP Twin Cities branch. Thank you, Dr. Samir Bhai, for being with us. I know you're very busy today. And my thanks, actually, I came to know about Dr. Leena and Dr. Zafar Menai sir through this recently conducted Poor Scholastic Performance PSPP 2.0, wherein I had an opportunity to be the participant to become a trainer in future. Really, it was a feast for me. I spent 2 evenings not missing even a single presentation. Dr. Jafi Vinay sir, thank you very much. Though I didn't meet you, the way you communicate with us is so friendly, so like very close friends. I think that's how you are shining in developmental pediatrics with challenged children. And I'm sure your Umid developmental pediatrics is doing a great service in India and as well, hopefully abroad as well. And Dr. Leena Madam, we have all regards for you. You are one of these few senior most developmental pediatricians dedicated for this developmental behavioral issues of children. I came to know about you, I'm sorry to say, but through this TOT program, and I am fortunate enough for accepting my invitation. Dr. Pratima Giri, we have special regards. I had 2 occasions to participate along with her in academic meets. She's an excellent speaker, and I'm sure it's a gift to our Hyderabad and Telangana to have a developmental pediatrician of that caliber. Thank you, Dr. Pratima. And my special regards for our young and rising stars of Hyderabad. Dr. Shruti, again, she's from Kolkata, then from Nagpur. She did her fellowship from under the guidance of Dr. Leena Srivastav. Dr. Sana is always ready on my phone call and keeps helping me in giving suggestions. And as well, Dr. Dedipya, she'll be joining us very soon. She's with Fernandez. They had started an exclusive child development center by the prestigious Fernandez Hospital at Hyderabad. And Dr. Rishikesh, he did his pediatrics. Then subsequently, he did his MD psychiatry and is working as an assistant professor in child psychiatry at Nilofer Hospital. So sincerely, thank you all once again for being with us and for gracing this occasion. And I'm sure all my co-participants will have a great learning experience. Lastly, I think you should correct me, around 20 to 25% of our children, adolescents are suffering from some or the other developmental issues, whether it is intellectual or behavioral or emotional, whatever it is. And a city like Hyderabad, unfortunately, has hardly a dedicated, not more than 8 centers, and it needs more than 30 centers. So with your guidance, with this symposium, I'm sure some of my colleagues will be stimulated. They will start this program. Once again, my sincere thanks for you all sparing your precious time and spreading your skills and knowledge to my co-participants. Thank you, Ananda. Over to Dr. Aris.
Thank you, sir. Thank you, sir.
Dr. Aris, are you available? Dr. Arjun, now I request you to conduct the proceedings. Dr. Arjun is our past IAP Twin Cities branch president, very dynamic person, practicing pediatrician. Over to you, Dr. Arjun.
Good morning, Dr. Bhaskar. At the outset, let me congratulate the team of Dr. Bhaskar. They're doing so wonderful academic programs and almost week after week. And very good to know. And especially you brought in this kind of subject, which is need of the hour. And I was told that Telangana has got more number of autism cases than any other state in the country. And as a practicing pediatrician for over 30 years, I wonder why the parenting has become so difficult these days. Those days, people see, I'm the 10th child of my parents. Likewise, those days, they used to have large families. The parenting was not so difficult. Nowadays, to bring up 1 child or 2 children has become a daunting task. And when I began my pediatrics PG career, we used to read about Illingworth. I'm sure everybody read about normal child, abnormal child by Illingworth. But I never used to give much importance. But I understood the development and milestones, everything, while parenting my kids. Both the children are pediatricians now. And now I'm doing for my grandchildren also. So to observe your own child, it will give you a good perspective about the milestones, the development, and how to bring them up, how to have the psychosocial interaction with them. So, and at times I really wonder, and I feel helpless when I diagnose an autism child. Almost 5 cases per week, I diagnose autism children, and then I refer to the regular developmental pediatrician. And I'm very happy today we have a galaxy of neurodevelopment pediatrician, starting from Dr. Pratima, Dr. Leena, Shruti, Sana, and the great Dr. Suchit, and our the most lovable our Mumbaikar. So very happy that the galaxy of stars are there, Dr. Samir, on this platform to educate us. And as Dr. Krishna said, it's becoming almost like a pandemic. and we really need trained professionals to handle all the children and also the parents. So it's very good to have all these programs, and most of them are big names in neurodevelopmental pediatrics. They don't need interaction. And since we are running short of time,
Dr. Arjun, may I interrupt you?
By the initial 4 lectures and subsequently panel discussion to be conducted by Dr. Suchit.
Dr. Arjun,
Dr. Pratima.
Dr. Arjun, there is a little change. With the permission of Dr. Pratima, we would like to have Dr. Samir Dalwa as the first speaker because he has to attend another academic event. Hope you don't mind.
It's very good, Dr. Samir, to open the innings. Sir. Over to Dr. Samir. Good morning to you, Samir.
Is it all right, Dr. Pratima?
Absolutely.
Thank you.
Yeah, good morning, respected seniors, my dear friend, Dr. Sankosh Bhaskarji, Dr. Arjun sir, Dr. Sri Krishna RSV, Dr. Kondle, all the office bearers of Iaptcb branch, all our other friends, all my respected co-faculty, Dr. Leena Srivastava, Dr. Zafar Minai, Dr. Suchit, Dr. Pratima, Dr. Sanashnati, all my other respected co-faculties, all my other friends from the Iaptcb branch as well as all across the country. Thank you. It's a pleasure and honor. And when Sankosh Bhai called me up, it was no question of saying no, though I'm in Rajkot today. And there is a West Zone Pedicon going on and I have a talk after some time. So Dr. Pratima, thanks for adjusting for me and giving me the opportunity to go first so I can present as well as leave after that. So I'll begin with our presentation quickly. And is the presentation visible?
Yes, sir.
All right. Yeah, so just like our friend said just now, there is like an oncoming pandemic of neurodevelopmental disorders, and we are short of, so, we feel trained professionals to deal with it. My entire presentation is going to be focused on general practicing, regular full-time practicing pediatricians. Because if we have to deal with, like Sankosh Bhai said, 20-30% of children having some problem or the other, it is never possible to have specialization for such a large number. And just like we are very competent to manage asthma in our clinic, we are very competent to manage malaria or typhoid in our clinic. I think we should be more than happy and competent enough to manage these disorders. They're not difficult at all. The problem is there has been a particular kind of teaching which tells us that, oh, you only identify the child and then you send to me, I am the developmental pediatrician. I don't think that's very, very important. And we are going to look at a case-based learning of neurobehavioral disorders, because what scares us as practicing pediatricians is the variety in the clinical presentations, and that often confuses us, scares us, and we want to refer the child away. Of course, what I'll be quoting from is most of my learning and my work has not come from books, but from the children I've been seeing over the last 20 years at New Horizons, and of course a team of wonderful people that I have had the opportunity to work across 5 centers in Mumbai and across the online branch that we have. And this is some of the data that we have collected from 2009, and all my colleagues who spoke before me, Dr. Arjun, everybody else. Yes, the number of children that we are seeing in each developmental center is increasing, and we were shut down during COVID, but immediately after that, look at the sharp increase in the number of children coming to us. And the new methodology that we are working at our center is involving the pediatrician and the developmental pediatrician on a monthly basis. And this is the result that we are seeing. So I'll quickly come across to some cases which all of us see, and looking at it tomorrow morning when you're in your clinic, probably you will have a 1-year-old male child brought to you for your opinion. There is nothing wrong that the parents have, but they have an older 4-year-old child with autism, and they want to ask you, what will you do? Since there is no time for interaction, which I would have loved, otherwise maybe next time we'll be in Hyderabad and do this face-to-face. The message here is what is to do always when you have a 1-year-old child with a family history of autism. Check all developmental milestones. Don't stay restricted thinking, oh, he has autism, that's scary. The brother has autism, he may have autism. Let me refer him to a developmental pediatrician. There's none available. What shall I do? Not needed. You are the competent person. Check all developmental milestones, gross motor, fine motor as well, because you never know, this child may have a global developmental delay or may be completely normal. And check vision and hearing for every child. That's the message from case 1. Case 2. 18-month-old male child is brought to you for not speaking many words. Parents report that the child uses pointing and gestures well for communication. So when he needs something, he's able to make actions, point out to the glass of water, do like this for a glass of water, but he's not speaking many words. What will you do? Most of us will say, wait, father spoke late, he will speak late. multiple languages at home, he will speak confused, so he'll speak later. That's actually not the right thing to do. And what is very important is what to never ever miss is hearing impairment. So every child, we have at 18 months, any kind of complaints, even before that, where we feel that the child is not developing well. In fact, the IAP also talking about neonatal universal screening for all children. Never ever miss a hearing impairment. And similarly, never ever miss a visual impairment. Moving on to case number 3. We have a 2-year-old male child. We are increasing, the age of the child coming to us. Again, the same complaint, not speaking much. Parents say he does not follow the instructions. When they call out his name, he does not respond. He does not, come here, sit down. He doesn't understand all this, but he can recite all nursery rhymes and film songs. There are no repetitive behaviors like spinning or rocking. What will you do? Similarly, case 4, little different. Again, 2-year-old male child. Parents say that when we call out his name, he does not look in our direction. But he is very good, can recite alphabets, numbers, but does not follow instructions. And yes, he is hyperactive, keeps running around the house, breaking the furniture. There are no repetitive behaviors in his case. What will you do? Now, both these children, we must understand to have a clinical approach based first, again, rule out a hearing evaluation in every child with such complaints. Second is a clinical evaluation. We will talk about looking at the red flags. But what all of us through the medium of IAP, Nurturing Care ECD program, which all of you have made successful across the country, we have all learned about the importance of screening using a tool called MChat, which is an online freely available tool, which all of us are expected to use. Looking at the clinical evaluation, these are the red flags you must keep in mind. There are no big smiles or joyful expressions by 6 months of age. So when you have that previous child, go back and take this history. No consistent response when child's name is called, which should be able to do by 10, 11 months of age. Does not gesture or point, wave, show, does not use non-verbal language by 1 year, and does not say single meaningful words by 16 months of age. And finally, just to make the thing more interesting and pleasant, there is this SRK sign of autism that we speak about at our center at New Horizons. What is the SRK sign of autism? At least the ladies here would surely know that SRK stands for Shah Rukh Khan. And this is the standard classical SRK pose. And when he does this, the heroine is expected to understand that he wants to hug her, and she will go running into his arms and hug him. This is basically a normal development. And normally by the time the child is 10, 11 months old, if the mother or the father stretch out their arms, the child has to go running into their arms and embrace the parents. That is a sign of normal development. If the child is not doing that, that is a red flag we must keep in mind. Besides, if he was doing any of these things earlier, but is now lost that or is not doing it, there is a sign of regression. That's a red flag. He does not play with toys appropriately. He just keeps turning the wheels of the car or opening or shutting the door, or he keeps lining up all objects. He has odd movement patterns like toe walking or repetitive behaviors like hand flapping, finger flicking, spinning. All these are red flags which you must keep in mind. And hence, when we do the MChat, between 16 to 30 months of age, any child with problems like what we described, please do an MChat. There are 20 questions, very simple, takes 5 minutes. And the score is less than 2, it is risk of autism. 3 to 7 is medium risk, but beyond 8 is high risk, and you need to refer immediately for assessments and interventions. But every child is not going to be above 8. There will be so many who will be up to 7 or below 7. What will we do for all these children is important, but most important, do something. If it is 3 or more, don't sit on it. Don't use, oh, it's okay, come back next month. Father spoke late, so the child will speak late. Parents say, oh, nothing, we are not worried. But you tell them that I am worried because MChat is showing a score of more than 3. Next case, 5-year-old male child is brought to you for hyperactivity and aggressive behavior. He does not sit in his seat in class. Similar complaint, isn't it? Similar complaint. Parents say he says some words repeatedly, but does not talk with them. He flaps his hands when he is happy, excited, and he keeps playing or spinning the wheels of the car. What will you do? And hence, when you look at this case here now, all right, there's a problem with the video, but what we are trying to say is that if there is a problem with the child's social communication, if there is a problem with the child's social interaction, we call it a social communication disorder. Simple, because social and communication. So social communication disorder. In addition, plus, if there are repetitive behaviors like hand flapping, finger flicking, spinning, Or there are restricted behaviors like restricting his attention only to the wheels of the car and not the whole car. Then the diagnosis is an autism spectrum disorder, which we have to keep in mind before we rule out and we go to any other concerns. This is a typical lack of social interaction, social connect, social communication. But you see these repetitive actions that are going on. No speech coming up here, rocking movement as you can see, without any meaningful interaction. All this is typical of autism. A 4-year-old girl child is brought to you. She is not hyperactive. Different case. Sits in her seat in a quiet corner in the classroom. In fact, does not like to be disturbed, nor does she like to be involved with anybody in the class. Parents say she says some words, but not quite a lot. She used to have some repetitive behavior. When you ask them for history, did she have hand flapping? Or, हाँ, पहले था, अभी नहीं है. She is good at it, but doctor, she is very good. She is copying everything from the board. So teacher has no complaints with her. She is doing everything in the classroom, doesn't even disturb the teacher. So teacher is very happy. But we feel there is something wrong. When you look at this case, look at some very specific points. She is good at copying alphabets, words, and numbers. She does not interact with anybody in the classroom. She says some words, but repetitively. She used to have some repetitive behavior earlier. When you see all of this classically, you will see it is autism. And into inverted commas, good academics. It is actually not good academics. It is only pattern learning or rote learning or copying. But parents will delay bringing this child to you because the child doesn't have any complaints from school. And hence you must be aware that this child has autism and not to miss it because there's poor social interaction, social communication, repetitive behaviors, and restricted interests. 7-year-old girl child brought to you. She's not doing well in studies as well. Teachers have pointed out she has difficulty learning what is taught. Similar or different from the immediately previous case. But what is similar? Teachers say she seems lost in her own world. And when suddenly asked a question, she's not aware of what is going on. Again, similar, she is not hyperactive, similar to the earlier child. She also sits in her seat in a corner quietly. But, whenever involved in any class activity, she is very happy. She's very happy to interact with everybody. What will you do? In this case, we must understand, most of us will say this is autism. This is not autism. We have to check all milestones. There was no delay except a mild speech delay in this child. The main complaint always is daydreaming, can understand concepts when one-on-one. So if you explain to her, she understands. And when you involve her with a team, she can do well in team games. And hence, this is not autism, but this is ADHD, which is the inattention variety of ADHD. We don't need to miss this. 10-year-old boy, grade 4, comes to you with history of poor school performance, good at academics. Dr. Sankoj was talking about the PSPP program, which we did last month. Similar story, good at academics earlier on, but started dropping from grade 1 and 2. Parents thought, oh, he's so cute, very mischievous when he was 3-4 years old. But teachers started complaining he does not sit in his place, keeps moving about, trying to play with peers. The other peers are sitting down, trying to pay attention to the teachers. He goes, disturbs them, keeps interrupting teachers, gets angry very quickly now, shouts back, answers teachers now. He has got into fights with peers and he likes to hang out with older students. What will you do? Very important to note that what is cutely mischievous in the pre-primary years, parents may feel, oh, ladka hai, masti karta hai, so what, he's so cute, may actually be a hyperactive, impulsive, and an inattentive child. And this is where the impulsivity comes in, interrupting teachers, gets angry quickly, wants to disturb others. And hence, again, we go through the same thing. He was always hyperactive and impulsive. He can't do well in team games, not because he can't interact, but because he can't follow the rules of the game, because he's too hyperactive, he's too impulsive. But he has good interaction. He is lacking academically, but can understand concepts when in short or when one-on-one. So he has no learning disabilities or dyslexia. And hence, this is an ADHD combined presentation with poor scholastic performance that we must keep in mind and not to miss. 12-year-old boy diagnosed with autism at 3 years at New York is brought to you. He has received multiple medications at multiple times. He has received intense speech therapy. All of us are so fond. Refer to speech therapy. Any complaint, refer to occupational therapy. This child has received all of this remedial education sometime, then counseling, then ABA, art-based therapy, music therapy, color therapy, stem cell therapy, which I also call magic therapy because it is just unrealistic. And that's the right word for it. Again, why did parents not bother so long? He's good academically, copying from the blackboard, memorizing tables, memorizing nursery rhymes, but has terrible social manners, has defined behaviors, now at 12 years, does not follow anybody's commands, wants to do his own thing, cannot be taken to birthday parties or Diwali parties or to Ganpati or any relatives or neighbors' homes. What will you do? Well, this child definitely needs referral, but what you must do by looking at this child is understand that there is also a type of autism which we are helping create by referring for multiple arbitrary diagnoses, arbitrary concerns, arbitrary interventions, and hence this child has worsened because he was poorly managed in spite of being picked up at age 3. And hence what is very important is don't refer arbitrarily left, right, and center unless we know what is the program. Going ahead, 8-year-old boy with academic difficulties, inattention, learning difficulty. Parents say he's very shy, he's not interacting, he doesn't like to mix with anybody. Again, multiple therapies, school was giving remedial education. When he came to us, we took a history which was suggestive of global delayed development. And he could not do simple activities when we asked him in the clinic. Does your child help organizing things at home? Does he entertain relatives? Simple transactions in shops. Is he being teased and bullied by peers? The answer was yes, he is being teased and bullied. And when we did a TP-PCR for Fragile X, he was positive. And this was what was being missed by all the multiple speech therapists, remedial educators, because they are not expected to pick up this. Who is expected to pick up this? The practicing family pediatrician of this child. 2.5-year-old female child, not speaking many words, similar complaint like earlier. But parents say that there is something wrong because she was doing well in the first 1 year, had started recognizing parents and family. She was calling out to her mother. Around her first birthday, she started losing interest in parents. She stopped saying anything. She was rather lost looking at her own hands and moving them in a particular manner. What will you do? This, I'm sure all our pediatricians will pick up immediately, is the typical regression of ASD, which is Rett syndrome, MECP2 missense mutation that all of us must understand to pick up. Finally, a girl with episodes of palpitations, sweaty palms, fainting. After lockdown got over, she started going to school with all this. Examination by the pediatrician was normal, ECG, EEG normal. Does not want to attend school or meet peers, cries easily. She was academically always below average, but a happy child. Teachers said earlier she was a happy dreamer, but poor at reading and spelling. Now she has become very, very stressed. Parents blame lockdown. What will you do? Well, this is missed ADHD with LD, which was there even before COVID. Because asking parents history of pre-COVID, pre-lockdown behavior in academics is important. Have a look at the notebooks. Ask the child read out to you. I'm sure my other colleagues who are presenting will give you the details of learning disability, but don't miss inattention as a presenting symptom of ADHD. The impact of lockdown is there. It has worsened LD and academic performance and pushed the child now into anxiety and depression. This is a child, incidentally, I saw from one of the online referrals, referred to our center for speech delay and slow progress with speech therapy. 3.5 years post-lockdown, parents noted poor speech. He was diagnosed with hearing loss. Hearing aids were bought for 50,000 rupees. Speech intervention for hearing was started. When he was referred to us, just because he was not doing well, the moment the camera switched on the online consultation, I could see that the child had poor social interaction, no eye contact, no social smiles. That SRK sign, like I said, came up. Restlessness, he was addicted to the screen. I was shocked because it looked like a child with autism. But how can I say that to a parent who has seen 2 doctors physically who have said hearing loss? We asked him to come to Mumbai. His developmental history was classical. His assessment was classical of autism that proved the diagnosis. So this is autism wrongly managed. And why is that? Because we think speech delay is a disorder. It's not a disorder. It's a symptom, not a diagnosis. Language disorder is a symptom, not a diagnosis. Repetitive speech after intervention is a complication called echolalia. It is not an improvement. Hyperactivity is a symptom, not a diagnosis. So do not refer for working on speech if the child has speech delay or language delay, or working on hyperactivity. You cannot work on cough. You cannot work on fever. You cannot work on sneezing. You cannot work on vomiting. These are all symptoms. You need to go to the underlying diagnosis. And hence today what we are seeing, all this focus on swinging, balancing, repetitive speech, copywriting, memorized phrases, phonics is actually not an improvement. It is a worsening. So are we giving the right advice? Hence the first thing is trying to understand the clinical signs, come to the right diagnosis, counsel the family. If referred, keep a focus on the quality of intervention. Is the child improving wherever I have referred him? And hence follow-up by the pediatrician is very important. Counsel all parents that don't start with symptom-based intervention. Symptom-based intervention is like keep giving paracetamol for fever. If it is viral fever, it will get all right in a viral infection, will get all right in a few days. It is tuberculosis, it is going to get worse only if you keep giving paracetamol for the fever. Of course, restrict screen time as much as possible and refer to a developmental pediatrician or quality organization if you have not been able to help the child with all that we discussed earlier. Monitor yourself. Please remember, autism is not a speech disorder or learning disability, not due to father speaking late. And I'm sure my co-faculty will take you through the details of all of this when they present. Finally, this is a methodology that we have developed at New Horizons Child Development Center, which is moving away from symptom-based therapy to sequence-oriented interventions. I will not take a long time, but we've been able to scale it up and even offer online parent coaching as long as you have a very clear methodology. These are some of the wonderful testimonials from our parents. Key messages is you as a pediatrician are the key professional. Arbitrary consultation and therapies rarely help completely. Hence, your follow-up is very important. Refer wherever there is an overall program rather than individual specialty or symptom-based therapies. And there are no fixed programs. These are some of our wonderful colleagues who work with us and our mentor, Dr. Rashid Merchant, our teams at the 5 centers. This is the book that the Indian Academy of Pediatrics has come out recently, Handbook on Developmental Behavioral Pediatrics, available all across the country and online. And finally, an invitation on behalf of Central IAP to all of you to the 30th International Pediatric Association Congress and 60th Medicon. Thank you very much for a very, very patient listening. Thank you very much.
Thank you, Dr. Samir. It's been a wonderful presentation, lively, emphatic, forceful as always. And you're doing a wonderful job at your New Horizon as a dynamic neurodevelopment pediatrician. Thank you very much for coming over despite your busy schedule.
Thank you so much. Thank you.
Next, we have Dr. Pratima Giri.
Good morning.
Pratima, ma'am.
Yeah, Dr. Arjun, kindly introduce her.
Yeah, Dr. Pratima Giri is a noted pediatrician, a neurodevelopment pediatrician from Department of Neuroscience, Rainbow Children's Hospital, Banjara Hills. Having graduated from India and then obtained a gold medal in MD Pediatrics, she moved to New Zealand and Australia. She specialized in neurodevelopment pediatrics, and having worked there, and she's come back, relocated to India, and she's heading the Department of Neuroscience at Rainbow Hospital. And more important, she's a lead investigator on the gut microbiome in cases of ASD, and she's leading the neurodevelopment center at Rainbow Children's Hospital. So, Dr. Very grateful to have Dr. Pratima on this panel, as well as to be in our city to head this department. Thank you very much, Dr. Pratima. Over to you.
Thank you. Thank you, Dr. Arjun. Thank you to Dr. Bhaskar and the Twin Cities branch for this opportunity. And thank you to everybody out here to have turned up on a Sunday morning for this webinar and symposium. So my topic today is challenges in the management of autism spectrum disorder. 20 minutes is a bit of a challenge to present aspects of autism, but I'll try my best, and apologies if I exceed the time limit. This is the roadmap of my presentation. So Dr. Samir Dalwai's talk was a nice start to the themes developing today. I'll touch upon these challenges briefly, diagnosis, comorbidities, a little bit about psychopharmacology, intervention, and some reflections. So I think the first big challenge is the numbers, the rising prevalence. And if you actually look at the numbers, CDC has put it as 1 in 44, and this is the most latest figure. Over the last 10 years, consistently, this number has been increased. So if you look at a constant diagnostic criteria of DSM-5, there has been a steady increase. I came across two figures in India, a census figure and another study, which is kind of indicating a prevalence of 1 to 1.3%. That is a big number. And all of us have experienced increased referrals into our respective departments. And this is not just in India. It's, the last 20 years that I've been abroad in New Zealand, in UK, there has been a steady increase. So that means we need a lot of trained professionals to diagnose and manage this effectively. I just want you to briefly think about the impact of autism. If you've known an adolescent or an adult with autism, you know that it's not merely in the pediatric age group. They have issues with schooling. There are huge problems. Even if the person is intellectually fine, there are issues with socializing, employment. Even if they have had sort of educational qualifications, there are problems with independent living. And the cost of therapy on a monthly basis is upwards of 30,000 in the initial therapy phase. And it's a huge emotional burden to the families. I also want you to think a little bit about some of the big picture issues. In Hyderabad, apparently we have about 400 therapy centers. But if you went a little bit towards the rural areas or towns, 100 kilometers, 150, we have far few of these. And autism is not sparing anybody. The other day, I had a farmer's child coming with autism, and it's not merely confined to areas which are, urbanized. Then a parent yesterday told me that he simply cannot get insurance, and the cost is about 50,000 he's spending from his pocket. We have a Disability Act in place, but there are figures which show that a lot of our kids don't access more than primary education. And that's an important aspect. Although the act is in place, there is difficulty with access, and special schools is also a problem. They are coming up, but is it matching the need is the big question. Now, what is going to happen to these children when the parents age? So what about respite facilities? What about long-term residential facilities for these children? There are a few coming up, but again, is it matching the huge raft of kids that have come through the pandemic? Again, a question for the policymakers. So there is some infrastructure, but not matching the need. So this is a societal problem, and this is the point I wanted to convey today. Coming to diagnostic challenges, you probably recognize this. This is the DSM-5 criteria for autism spectrum disorder. Now, unlike the Jones criteria for rheumatic fever, none of this has got biological markers or clinical markers. These are all behaviors, social behaviors and communication. So the big challenge is for a lot of pediatricians in your short consultations, say if you do an average of 10 or 15 minutes, this is not easy to be diagnosing, observing these behaviors. These need time and therefore need referral to either the pediatrician who is specialized in developmental pediatrics or a developmental pediatrician or a psychiatrist or neurologist, whoever does these assessments. In New Zealand, I've done a combination of assessments. I've done assessments on my own and also multidisciplinary, which is along with a psychologist. And these are quite gold standard assessments, but these are very resource intensive. Now, as per the Indian Association of Pediatric guideline, there are a number of tools that are suggested to use. The INCLIN suggested by the ministry, there's ISA, CARS, ADOS, and ADIR. Now, within autism, level 2 and level 3 is very straightforward. Sometimes people at your reception might be able to diagnose this, but it's the level 1 or the mild that requires a fair bit of teasing out. And this requires time and information gathering. And therefore, again, emphasizing that these assessments require time. The other one is girls who present with autism often present late because their diagnosis can be quite challenging. We tend to diagnose boys quite easily, but girls are often present late because their presentation is a bit different to boys. So do not rush to label children, but you can work on a tentative diagnosis, take time to gather data, and refer on. I just wanted to point out some of these really good resources. This is the IAP guideline, which I have found very useful. This is the one on the right is the Indian scale for assessment of autism. That again are two really good resources that pediatricians can use. I tend to use two things. If you remember Dr. Sameer's talk about assessing development in each child, I do assess a development completely in every child, along with applying the DSM-5 criteria. And this was developed by one of our senior pediatricians in New Zealand called Dr. Russell Wills. And what is really nice about it is it's a compilation of all the milestones. And when I mark this, it gives a really visual aid to parents to follow what the developmental profile is. What I usually find is that there is a disproportionate language component. So you have a bell-shaped line of development. Also, you find a number of children presenting with fine motor problems or problems with toileting, and many will present with cognitive issues. So the second challenge in diagnosis is early diagnosis. There is evidence that early diagnosis leads to better outcomes, and late diagnosis is a missed opportunity. And although I'm getting some really sharp young parents bringing their kids under the age of 1, the large majority do present late. And they attribute it to all sorts of things like excessive gadget use or the family is in denial. So coming to the IAP recommendation, it recommends mandatory screen at 18 months. American Academy of Pediatrics recommends at 9 months, 18 months, and 30 months. So important that all of us are aware of the red flags of autism. And you find that these are sort of red flags pertaining to social communication. Not turning to name is the big one. And in terms of behavior, it's those RRR, the rigid, repetitive, resistant, restricted behaviors, and the sensory behaviors to watch out for. Children tend to be in their own world. They don't mix with peers. They flap. And then there are restricted interests, which are unusual items. So these are usually the red flags. Also important to be aware that sometimes you may not have very prominent features, but you could have absent normal features. So that, like Dr. Dalwai mentioned, absence of that warm, reciprocating, joyful expression in the first 6 months, and a quite undemanding baby. So in terms of screening, the key points are be aware of the red flags. There are a number of tools recommended by the IAP, the MCHAT, easily available, the Trivandrum checklist, the social communication questionnaire, and think about this when your child presents for vaccinations or for whatever reasons under 18 months, screen this child. A third diagnostic challenge is the conditions that mimic autism. There are a number of other conditions that can present as autism, and I find that at times I'm undiagnosing autism. One of the big ones is this this isolated speech delay or the developmental language disorder. I do get a fair bit of ADHD presenting as autism or the developmental coordination disorder, DCD. But one really big one that I see quite frequently is reactive attachment disorder that presents as autism. And this requires sort of further assessments with the psychologist. I'd like to speak about a few challenges with intervention. So children with autism they present with multiple challenges, and it's not merely communication. They have problems with socialization, sensory integration, as well as behavior and learning. And therefore, they require strategies which support not just communication, but learning, socializing, sensory integration, and behavior. And therefore, you can see we need a multidisciplinary input to manage these children. And for each child, this is unique and has to be tailored to that particular child. So a fair bit of thought needs to go into planning the intervention of a child. The second point I wanted to make an intervention is that with regards to speech therapy, the important component is the pre-verbal skills. Very foundational to developing language and speech is what is called joint attention. The other pre-verbal skills being pointing, intention to communicate, and eye contact. It's hard for children to progress with speech therapy unless joint attention has been addressed. And this is an important aspect of speech language therapy. A quick peek at the evidence base for intervention strategies. And when you look at what is the evidence, which one works, the best evidence actually comes from the combined developmental and behavioral approaches. And one of the examples of this is the early start Denver model. There is good evidence for approaches such as the Hannon approach, as well as the flow time. All right, coming to another big one. Autism rarely occurs on its own, and it's important to bear in mind that there are many comorbidities. Another reason that these children require a detailed assessment. And there are comorbidities that occur along the developmental domain, the medical domain, behavioral problems, and psychiatry. Autism is a complex the checklist that I showed you before, the DQ of the children or the developmental profile, you find a number of things, but mostly you find a disproportionate language delay. But you do pick up issues with motor, language, self-care, cognition, and personal social. Another thing to bear in mind is that even their cognitive profile can be quite uneven or spiky. Certain aspects are good and certain aspects are delayed. 30% of these children have got very significant learning difficulties, and therefore it's important to sort of be aware of the issue with schooling. Even if this child is intellectually well, they require autism-specific strategies within the classroom. And therefore, it is important to be sharing this and advising the class teacher about the strategies to support this child to enable him to go to his full potential. And this could involve things like sort of sensory room or breaks or transition. The role of a pediatrician becomes quite important in advocating for these children and working with school. Now, there are many medical comorbidities in autism, but sleep is an important one. And a large majority of these kids, upwards of 50%, have got sleep issues, and therefore important to assess this and then advise sleep hygiene. And in a number of these, we tend to use medications such as melatonin or clonidine. Feeding issues is another big medical problem in these children. You might find a lot of restricted eating habits and ARFID. A lot of the kids are not aware around the mouth and they stuff their mouth. You also have children who present with anorexia nervosa, especially the high-functioning older girls. So it's important to always review the growth parameters in these children and co-manage these children with the input of the dietitian and the SLT. There is evidence that concealing food within, for instance, carrots or whatever within doesn't help. It's important to address this. There are particular approaches to feeding. This is a big one in autism, challenges with managing behavior in autism. The common behaviors that you see in autism are the core features of autism, which are called the RRRBs, the rigid, repetitive, restricted behaviors. And the management of this is not just behavior therapy. Very often we find that things such as a good parent education helps with managing these. Parents being properly informed about what exactly autism is. Early intervention techniques also help. And very important that teachers and parents have autism-specific strategies. All this with behavior therapy helps manage these behaviors as a first line. In addition to the RRBs, there can be another layer of behavioral problems. 30% of these children can have mental health problems and a very formal psychiatric diagnosis. So they could present with anxiety, and there is a overrepresentation of these problems in children with autism. You could have ADHD and irritability and aggression, which become quite challenging for the pediatrician to manage, emotional volatility and self-harm. So how are these to be managed? These require specialist input. So either it is the pediatrician with special interest for autism, or the developmental pediatrician, or a psychiatrist or neurologist, along with a therapist, a behavior therapist. But it's not merely psychopharmacology alone. So the third aspect I wanted to mention with regards to behavior was about psychopharmacology. Now, unlike in the field of, say, cardiology or oncology, in this particular field, we haven't developed too many drug targets. So our armamentarium of drugs is rather limited. The two major pathways we use is the dopaminergic pathway and the serotonergic pathway, and to some extent the noradrenergic pathway. So the algorithm and the paradigm that I have sort of learned in my last 10 years in New Zealand and Australia has been about looking at children along these two major sort of classes of problems, either the mood and the sensory issues, for which a dopaminergic drug would be useful, like an atypical antipsychotic, and then another group which present predominantly with rigidity and anxiety. And in these kids, an SSRI is usually helpful. But again, these have to be trialed and tested, and you have to tailor it to each child. Hyperactivity is another problem, and then you use methylphenidate or atomoxetine. But the fundamental question to ask is, rather than just blindly throwing in a drug, is what behavior are you targeting? And what is it I'm hoping to achieve with this particular drug? I wanted to just mention a few words about risperidone. This is an excellent drug for managing irritability, aggression, and self-harm, but there is no evidence for its, and no trials under the age of 5 years. And therefore, if you have had to use this, it has to be with extreme caution. Ideally, have the input of another specialist. I also wanted to emphasize that it's not risperidone alone or BT. We do need a lot of other things to manage behavior. The role of an early intervention teacher is important. Speech and language therapy continues to be important even for managing behavior, and the role of OT. And in addition to this, there are other approaches such as recommending exercise, having a good structure and routine. So bear in mind, it's not just risperidone and BT for managing behavior. A quick word about behavioral crisis. We will encounter a small number of kids who will be resistant to any medication we do. So it's important in this that we start to involve either the psychiatrist or the developmental pediatrician. And this is the one in whom we might need to use a circuit breaker and aim for a good mood regulation, because these are huge challenges. They can exhaust the parents and they can exhaust resources. And important to understand this with a team and manage this well. Another quick word about CAM. A lot of parents will ask us this: diet, supplements, and stem cell therapy. Important that we guide them correctly and not fob them off. Important for us to be up to speed with the evidence. Up until recently, there wasn't much evidence about stem cell, but there are some encouraging studies coming from the Duke University. So there is a good guideline by the AAP on discussion, how you discuss this with families. So important for you to be well informed and presenting the evidence to the families so they can make their choice. I also wanted to mention about determining the cause and etiology, because every family will ask you, why did this happen? And the problem is that even for us, we do not know the cause. Autism continues to remain a puzzle. We do genetic tests, and in about 20%, we might have a genetic pointer. But as such, we do not know the exact etiology. And communicating this to the family to say, I don't know, is hard. Every family will also note the association of, particularly in this lockdown, asking me, is it because we both were working? Is it because we've had a screen time upwards of 8 hours, or is it because we've been isolated from our families? But the answer at the moment is we do not know for sure. I wanted to put this slide here. This is one of the ecological theories that we learn in child development. Now, when we look at child development, this doesn't occur in isolation. Think about the influences and in the house, in the immediate environment, in the micro, meso, exo, and the macro system. Think about what we've gone through in the last 2 years. Think about how, the larger political environment could influence children's development. But the big one has been the last 2 years with what has happened with the pandemic. Has any of this actually caused autism? So I really wanted to put this out there because in every single child that I document the history, I do come across social isolation, both working parents or busy parents, and increased screen time. What has really happened in the last 2 years? Is this time to actually start to have register? And is this a research opportunity to look at the holy grail of autism spectrum? Just a thought for all our colleagues out there. So finally, coming to the reflections, that time before 18 months, when children present to developmental surveillance is a crucial time with the kind of cases we are seeing, important to screen. Please ask those few questions or do them in chat. That the IAP ASD guideline is an excellent resource, and so is the tools like INCLEN and ISA. ASD is not a simple medical problem. It's a complex neurodevelopmental disorder with multiple comorbidities, and it requires time and a specialist assessment. So please refer early or upskill yourself using tools if you do not have access. Then important to emphasize those pre-verbal skills and things such as joint attention as part of speech therapy. And intervention involves an integrated approach with speech, OT, BT, and teacher, but tailored to each child. And please rationalize the use of risperidone and utilize it in combination with behavior therapy and non-pharmacological approaches. And your role as a pediatrician is crucial in identifying these children, screening them, and referring them early to specialist assessment and advocacy. So thank you very much. I'll just end with this picture of an endangered bird, the peacock. Thank you, Dr. Bhaskar.
Yeah, Dr. Arjun, are you available? Yeah, thank you, Dr. Pratima Giri. It was an excellent presentation. I still remember you said the discussion can go on ASD for 2 days, 3 days together. Despite the fact that such a vast specialty, you could complete it in 20 minutes. It was really very useful and eye-opening in many aspects. Thank you, Dr. Pratima.
Thank you.
Thank you so much. Now we will move on to the next topic, that is on ADHD by Dr. Jafar Minai. He has dedicated to this exclusive developmental pediatrics work since last 2 decades, and is a director of UMID, the group of child development centers at Bhopal, Nagpur, Apollo, Bilaspur. As well, he's going to start a few centers in Middle East. And he is the recipient of Madhya Pradesh State Government highest award, Maharishi Dadichi Award 2009 for Mission Disability Reduction. And he was a National Joint Secretary, IAP Neurodevelopmental Pediatrics, Chapter 2022. More than that, he is actively involved in all the academic fora, particularly related to child development disorders. Recently, I had attended his TOT program, that is a PSPP 2.0, wherein I was really very much impressed. So thank you, sir, for participating in our symposium and for enlightening us through your presentation.
Thank you, Dr. Bhaskar. Thank you for your kind words. I thank the organizing team for giving this opportunity and learn from the learned speakers. So, ADHD, and one of the most commonest behavioral issues. So I better wrote it as a story of ADHD. And can you see my slides?
No, not it.
We can see the title slide, Dr. Zafar.
But it's not moving. Just a minute, I will retry.
We are able to see a new slide now.
Yeah, Dr. Zafar, you're a co-host. You should be able to speak and also share your screen. I think I'll just change the setting. Dr. Zafar, I'm changing the setting so that you can unmute yourself.
Yeah, I am unmute myself now.
Yeah.
It was actually muted from your end. That was the...
No, sir.
Just
Co-host, you can always unmute at your end.
Okay, no issues. Do you think, can you hear me? Can you see the slides now?
Yes, sir. Go to full screen from beginning.
No, that's there. Yeah. Can you see it now? Can you see the slides?
Yes, please go ahead.
Okay. Sorry for the pitch, as always, because of my ADHD problem, I think. Anyway, well, ADHD, I think one of the most descriptive poems which I read was written by Heinrich Hoffmann way back in 1844 in Germany, the story of Fidgety Phillips. And I think the photo in itself explains everything. That is a child who is doing everything except what functionally is expected to do. He is falling apart, he has pulled down everything, he is just not able to eat. The thing was simple, he was supposed to and eat with the family. So that's how what we expect a child from ADHD. He would be knowing but unable to do or perform functionally what is expected. And when we talk about ADHD, the first and the foremost question comes to us is, many a times the families ask us, कि क्या मेरा बच्चा बहुत smart है? Is he overactive? Is he hyperactive? And the simple reason we need to be very specific is because if the child is smart, he would be able to function normally in the social, academic, or the personal, occupational activities which he is expected of. And in ADHD, we know it's the developmentally inappropriate levels of inattentiveness, impulsivity, or hyperactivity, which interferes with his functioning. Whereas the smart child would not be having such difficulties. Overactive would be more motoric, but still able to perform functionally well within the norms of the social domains. And why we need to know about ADHD? Well, one of the very common and most important reason is it's one of the most commonest neurobehavioral disorders found in children. Moreover, ADHD is not a problem with knowing what to do. It is a problem of doing what you know. पता है करना क्या है, पर कैसे करना है ये नहीं पता. This is what is ADHD is all about. It is a performance rather than a knowledge deficit. With the DSM-5 TR in place now, the heritability of ADHD is reported as around 74% and occurs in 7.2% children worldwide. And most importantly, it is the behavioral disinhibition, the basis of which forms the basis of executive function deficit in ADHD. The child is not able to inhibit his impulses, his behavior, his physical or impulsivities, and that is the basic root cause for the issue. And why it is important? Why it is important to differentiate a smart child from an ADHD child? It is because of the safety concerns. I find if you see a child at 3 years and you already know that already he had been getting stitching at 1 or 2 places on the head or some other issues, or at 5 years, you find similar scenarios that the child is not there. So we need to understand that these children are at risk. They are at risk of getting injured on the roads, falling down from steps, falling down from window balconies. So that is most important as general pediatrician for us to identify and work upon these cases and help them attain their maximum potential. The basic basic motive of my today's presentation is empowering the pediatrician, a general pediatrician, so that we are able to help them prevent such catastrophic events to appear and empower the families so that they are able to live a fruitful life. In India, I was with Dr. Leena and Dr. Samir. We are fortunate to be part of the national guidelines formulation, and we are very fortunate that we will be coming with the revised guidelines in 2023 by January. So in that, they reported, and I have quoted many of the slides from our national guidelines and DSM-5, the TR, which has just been released. And I would like to endorse here that the DSM-5 TR has not many changes except beyond 17 years. So for us pediatricians, it remains the same as the DSM-5. The reported prevalence is around 11.3%, and in few studies it even goes up to 32%. So what is all about? Well, it is about a syndrome with 2 categories of core symptoms. Inattention, which usually comes late. The child is thinking that is the all about everything at the same go, not able to perform anything. And second, the hyperactivity or the impulsivity, which usually presents early. It's just a motoric child a child with a key, jisko ke on kiya and he is just on the run, or jumping, blurting out answers even before the questions are completed. So these forms the core symptoms of ADHD. And we know that as far as the process and the onset is concerned, usually they say it presents by 4 years. But many a times you are able to even identify a child as young as 14 months, 16 months. I've come across a child who was around 14 and a half to 15 months of age. The mother already had twice epistaxis and needed gauzing, because the child used to box her in such a force that it was beyond her control to even stop him. Just a kid of 14, 15 months. And he had all the other symptoms at that very young age. The issue is not diagnosing. As Dr. Samir always says, and we also follow the dictum, it's more from labeling to enabling the families, and so that we are able to help those families what the child could do. If we don't intervene, the trajectory goes a very negative U-turn. Otherwise, usually it is observed by 4 years. They increase by 3 to 4 years, peak at around 7 years, and thereafter they become to decline, the hyperactivity part. Then comes the inattention part and the impulsivity part. And the focus of impulsivity is always influenced by the child's environment. We all know about the DSM, and we know the 9 symptoms. Majority of them of us know about it. The TR also, as I said, is the same. Most importantly is that the symptoms should be there before 12 months of age. So persists for 6 months, should be in minimum 2 situations. And for those less than 17 years, it is the 6 out of the 9 symptoms which presents, which needs us to make the diagnosis of hyperactivity, impulsivity. And for those beyond 17 years, it is 5 out of these 9 to make a diagnosis of hyperactivity, impulsivity disorders. The first is the excessive fidgetiness, unable to sit in one place, always stepping the hands or feet, difficulty remaining seating in one place, feeling of restlessness, inappropriate running around, climbing on chairs, falling down, difficulty playing quietly, difficulty to keep us seeming to always be on the go, excessive talking, difficulty in waiting turns, blurting out answers too quickly, and interruption or intrusion to of others. Any of the 6, if present, makes the diagnosis for hyperactivity, impulsivity type of ADHD. The same applies for the inattention part. The symptoms should be present before 12 months, should be persistent for 6 months, should be in at least 2 settings, should cause functional impairment, and should be, the count is again the same, that is 6 and 5. So for the inattention part, failure to provide close attention, making careless mistakes, difficulty maintaining attention in play, school, or home activities, seem not to listen, fails to follow through, difficulty organizing tasks, avoid tasks that require consistent mental efforts, and loss of objects required for tasks or activities. But very common presentation, you will always ask, if you can ask just a simple question to the families कि अपना सामान जो लेके आता है वो वापस लेके आ जाता है, छोड़ के आता है. If वो छोड़ के आता है, it most and very frequently it goes more in favor of inattention. अगर वो दूसरे का लेके आता है, it goes more into the oppositional defiance at the higher pitch ones. Easily distracted by irrelevant stimuli and forgetfulness in routine activities, which is the homework and the course, etc. We also need to be specifying whether it is a combined type. If both the criteria of inattention and hyperactivity are made for the past 6 months, it is the combined presentation. If it is only in the A1, which is the inattentive presentation, then 6, it becomes the predominantly inattentive presentation type. And those with the hyperactivity, impulsivity one are the one which have the criteria which meets for the last 6 months in that particular domain. And there is another issue now, because many of the children are receiving some sort of therapies or medications which they have not complied with. They may find a partial remission in these kids. And so when the full criteria was previously met, but then now the fewer than the full criteria have been met for the last 6 months, the symptoms are still persisting and interfering with the social and functional domains of the child, then we need to specify that it is the partial remission one. The severity is like in any other developmental issues, it might be mild, moderate, or severe. So not all ADHD means that the child is going to require all type of interventions. It might be a mild variety in which the impairment in the social or occupational function is not severe. The moderate comes, the severe are the ones which requires marked impairment in the social or occupational functioning and may require the therapies as we'll be discussing subsequently. Very important, when can the symptoms be missed? We know there is no test for ADHD, a biomarker, or for that matter, MRI, which can give us a diagnosis. It's a symptoms-based diagnosis. So one of the commonest way we can diagnose is by the symptoms, and the reasons we miss is because many a times the symptoms depends on the context within a given setting. And the signs of the disorders may be minimal or absent when the individual is receiving frequent rewards for appropriate behavior. If the families are giving simple tokens for whatever good he is doing, then these symptoms can be masked. Is under close supervision, is in a new setting, is engaged in especially interesting activities which he likes, has consistent external stimulation. Most commonest, the family says, Doctor Sahab, TV, mobile, 2 ghante dekhta hai. But the child is not able to focus on the book for a minute. It is because of a consistent external stimulation which these screens provide. There's a constant shift of screens per second in front of the eye, which makes him attached to that particular task and is interacting to one-on-one situation in the clinician's office. So it's not only the fear of the injection we doctors impose that the child may be sitting idle. It is because wo aapse one-on-one baat kar raha hai. So you might miss the scenario, and it can be mispresentation. So we need to specify with what 2 settings the child was affected. It might be at home, it might be at school, it might be at playground, it might be in the social settings, it might be in a functional area where he visited with the family. So any 2 settings can be, if the symptoms are present, we need to identify and label the child accordingly. So what is natural history? Well, the rule of thirds are applicable here also. Roughly 1/3 will go under complete resolution, 1/3 will continue inattention and some impulsivity, and 1/3 will have poor academic achievements, substance abuse, and antisocial adults. I think they are the one, unfortunately, which we missed as pediatricians. Age-related changes are the preschoolers usually present with the hyperactive impulsive variety. The school age 6 to 12 years usually present with the combined symptoms. The adolescents more with the inattention and the restlessness part. And those about 18 years, largely inattention and periodic impulsivity. As far as differential is concerned, it's first and foremost intellectual disability. It can be specific learning disability. It can be with oppositional defiance disorder, anxiety disorders, bipolar disorders, depressions. Medication, anti-asthma drugs are known to increase hyperactivity, substance use or abuse, post-traumatic stress disorders, and autism spectrum disorder. We as pediatricians are well versed, I think, with the entire spectrum. So it is much easy for us because we know if it is learning disability, all the domains will be equally affected. If it is a specific learning disability, it will be only in the specific domain of a topic of whether reading or maths or writing, which is affected more. Oppositional defiance disorders has its own presentation where the authoritarian figure, the child will just do whatever he or she opposite to what is guided or advised to him. Anxiety will always have that worrisome presentation. It might accompany ADHD, and depression can accompany with ADHD. Medications, I already said. Post-traumatic stress disorders, unfortunately, there'll always be a precursor or an event which leads to it. In autism spectrum disorder, I think we all know more of a communication disorder rather than and repetitive restrictive behavior presentation rather than the typical motoric with inattention and hyperactivity alone. So what we as pediatricians need to do? Well, most important, like in any other developmental issue, we need to go and take very detailed history and do a very keen observation. In the history, we must be able to expose the prenatal exposure of any tobacco, drugs, or alcohol, perinatal complications or infections, any history of CNS infections, any history of recurrent otitis media adenoids, history of sleep disturbances, family history of similar behaviors, any medication the child is on, anti-epileptic or anti-asthma, detailed child and family history, cardiac history, because that is very much needed once we start medication. Physical examination, most importantly, the child looks normal in the physical presentation, but never miss the vision and hearing part. In vision, we know amblyopia is one of the very important precursors, and the child usually presents with ADHD and would have schooling issues if that is not corrected. We need to rule out the differential diagnosis. Most importantly,
Bhaskar sir and Dr. Zafar. Yeah, I don't find Dr. Zafar in the participant list.
I'll call him.
Yeah, probably a internet concern. Shall we go ahead with the next presentation, sir?
Just I'm calling him. I'll let you know.
Sure.
He's not responding to the call. I think. Better we move forward.
Yes, sir. Over to you. Whoever is the next in order as you are decided.
Just a moment. Dr. Jafar sir, we lost your connection. I think you can restart and move the slides faster. Dr. RSV is trying to come back.
All right, sir. We'll just wait for some time.
Nice one. Score.
Please give me the screen sharing.
Okay, come on.
Hello.
Yeah, you can share screen now, Dr. Zafar.
And come on, Vijay.
Hello.
Yeah, we can see the slide. We can hear you. Go ahead.
Okay, thank you. So the recommended screening tools are there. As I said, there is no diagnostic modality to, I'm sorry for the hiccups up, everything is happening, as I said now. So the screening tools, which most commonly can be used in office practice, is the childhood behavior checklist, which is available free of cost online. The vulnerables is there, the corners is there. Any one of the tests can be used to label and identify these kids, their variety, whether it is a combined or the inattentive or the hyperactive impulsive, and associated academic issues associated. Well, treatment, again, I would say most important is a combination of behavior interventions and medications. And when I say behavior interventions, does it mean a psychologist? No, we as pediatricians need to be aware that very simple behavioral techniques can be employed, and we need to empower the families. What best we can do is require changes at the school level as well as the home level. For which the parents can be trained that in the school, the child can be made to sit in a preferential position in the middle row, in the first row, in the middle seat. At home, exactly like a school, a fixed timetable needs to be fixed up and needs to be acted upon, where the child is positively reinforced and immediately rewarded for sticking to the task which he has been assigned and successfully completing. And a combination is what is advised and suggested of medications as well as behavioral modifications. ADHD is one of the only developmental disorders in which there are definitive medications available, which we pediatricians can very well use. And for the medication part, we know the gold standard is methylphenidate, the stimulant, and it can be started by 0.5 milligram, raised up to 1 milligram per kg, maximum up to 60 milligrams. Now, the sustained release molecule is also available in India. The non-stimulant is the atomoxetine. Again, the dose is to start with 0.5 milligram, and maximum up to 80 milligram can be given. So with methylphenidate, we need to be ensured that it should not be taken at the night time. One of the commonest mistake done by the family is that if they miss the dose, they sometimes tend to take it at the night time. We miss in the morning. So that one parameter needs to be remembered. Second, we need to follow up with frequent growth monitoring of these kids and liver function tests. And with atomoxetine, again, it may lead to some degree of anorexia, but otherwise it's quite a safe drug. Very well can be used, but and should be used by all of us who feel that the child can be supported as a portal of therapy. I always say, what I mean by portal of therapy is to build up the confidence. And once that is attained, the child starts performing as per the fixed schedule which we had planned with the families. Then slowly and steadily, we can withdraw the medication. And when we need to refer to a developmental pediatricians, well, if there are any comorbid conditions, oppositional defiance disorders, conduct disorders, substance abuse, emotional problems, these are the kids who needs to be referred either to a developmental pediatrician, child neurologist, or a child psychiatrist. If there is any coexisting neurological medical condition of autism spectrum, seizures, tics, sleep disorders, or lack of response to a controlled trial of stimulant or stimulation therapy. If we don't treat, definitely there are issues in the academic domain, the social domains, there is always a peer rejection. These kids don't have good friends if the symptoms are not corrected, may lead up into criminal activities, may have inferiority complex and a very disturbed family life. So it is our responsibility to identify these kids at the earliest, help them blossom, plan for the island of excellence which each and every of these kids is having, and help them. And our education system, as Albert Einstein say, everybody is a genius, but if you judge a fish by his ability to climb a tree, it will live its whole life believing that it is stupid. Believe me and you together can bring a change in the life of these children. It's very simple, it's easy. Just ensure that we identify the issues at the earliest, start helping them with proper guidance at the home and the school level, and if needed, the starting medication at the right time, with the right dose. Thank you very much. I'm really sorry for all the hicks and hitch-ups which came in the presentation. I think it was a classical ADHD presentation where there was some impulsivity, there was some attention deficit, and I don't know, some technical errors. Thank you very much.
Thank you, Dr. Jafar Minai, sir. You started with one very interesting slide, a comic slide, and ended with another very useful slide. And you started your presentation with how ADHD cases present and how to pick them up in our office practice, and reposing confidence in the general pediatricians to go forward and diagnose ADHD in their offices, how to manage, and also to be mindful about the complications. Lastly, the slide is very interesting, that all of us together can bring changes in the lives of the disabled children. Excellent presentation, despite few hiccups, which are very common in our online presentations. Thank you, sir. Thank you very much. So nice of you. Now we will move on to the next presentation. It's by Dr. Leena Srivastav. I'm sure all of you know Dr. Leena Srivastav. She's a legend in developmental pediatrics in India. She did her MBBS, DCS, then she did the PGD DN in developmental neurology, and as well MA psychology. That's an interesting thing. And did her fellowship in pediatric neurology and epilepsy, and also honorary IAP fellow in childhood disability and early intervention. Presently, she's heading Child Development and Guidance Center at Bharati Vidyapith Medical College and Hospital, Pune. And also one of our panelists, Dr. Shruti, he's a disciple. So nice to see the combination. And she'll be presenting on intellectual disability. Thank you, Dr. Leena Srivastav, for participating here. And over to you. Dr. Leena Srivastav, it's your turn, please.
Yeah. Good morning, everybody. And thank you, Dr. Bhaskar and team, for this wonderful academic initiative. So since we're running late, let me just go to the topic in a rush. So it's wonderful that on Sunday morning, everybody's spending time learning, and I hope it's worth it. So I think when Dr. Bhaskar told me the topic intellectual disability, I think there was a pause from my end, and he said, oh, do you want another topic? So that was not it. What I always think is, as pediatricians, if we are seeing the children when they are already into a diagnosis of intellectual disability, we have sort of missed the bus, is something I always think. So I am not going to start from there, but I am going to start early with potential intellectual disability, right? So we see the children much before we see the children from the beginning. And I think as a pediatrician, our role begins much earlier. So let us start with this young child, 8-month-old child who's come come to you with developmental delay. We see this all the time. The child presently has neck holding, attempt to roll over. Mother reports that he's not yet sitting or creeping on his abdomen, and so she's worried. He coos and reciprocates, and mother reports that he does occasionally say mama, but not too often. The child had been to a doctor in their hometown where the mother was during the lockdown, and they had been advised MRI brain and a few investigations for the developmental delay. But since you have been their doctor for the previous 2 children as well, they come to you and they want your valuable opinion. Now, how will you proceed? I think time and again, all our speakers have told us that a detailed history and examination is the way ahead. So that's exactly what you do. There's full-term normal delivery, birth weight was 2.5 kgs, neonatal jaundice was there, but that was managed with phototherapy, dietary history, exclusively breastfed, but then you can work on it. He's 8 months old child. But then when you look at the child, that is something that strikes you. Neurological examination, head circumference was normal. The child did appear a little lethargic and hypotonic, but nothing else really significant. And then you look at this child and you wonder, oh my God, has he been newborn screened? Okay, so what will you do next? See, in a country where we do not have newborn screening, we definitely must keep our eyes open to a lot of conditions that are not routinely given that much importance in literature, because most countries abroad have a very good newborn screening system. Anyway, you go ahead with the ophthalmic and the audiology evaluation, which every speaker today has told you. Then also you have a developmental pediatrician in your hospital, you all do a DQ, and then you realize, of course, that your child is delayed on both domains, motor and cognitive, and it's suggestive of global developmental delay. I would like to bring your attention that we have these very easy and simple to follow diagnosis and management of global developmental delay guidelines, consensus guidelines, which were released in 2022 by the Indian Pediatrics, and they're published in the Indian Pediatrics, and we were all part of the task force. And I think it's a very simple thing to, refer to or keep as a quick, reference when you are dealing with a child with developmental delay. So the detailed history and examination, which you've already done, the hearing and vision you've already done, the DQ is definitely less than 70. So then you go to the first column, and we will come to that in a bit. You look at the investigations. Now the MRI was done because the doctor earlier had referred, but then you do your basic workup because you're referring to this slide and it says investigate for treatable causes. So thyroid function test, iron, vitamin D deficiency, etc. And here vitamin B12, sorry. So here you do a thyroid function test and you find out T4 was low and TSH is greater than 100. Of course, the other investigations were already done and they were normal. I just want to highlight that do remember to look at the treatable causes in every child coming to you with developmental delay. It is interesting, but we had this really, CP child who came to us all the way from Gorakhpur to Pune. And, we were wondering that how much we could contribute or help this child in that visit. And they were due to catch their train. And, we had sent our routine investigations, which as Shruti will know, every fellow is supposed to do the treatable conditions workup in every child. So this was a really spastic quadri CP. And just when the train was due in the evening, in the morning, we came to know that the TSH was greater than 100. And due to that, the child subjectively did a little better than, the regular interventions, and it did help the child in the long run. So never, ever forget to screen every child with developmental delay after a good detailed developmental history and an examination and a hearing and vision for the treatable causes. So, of course, this child was managed with the early intervention with all the developmentally appropriate goals, with the multidisciplinary approach that all our speakers have been speaking about, with the specific management of hypothyroidism in addition. We must remember congenital hypothyroidism is a very common and easily preventable cause of intellectual disability. So even before coming to the actual cases of intellectual disability, I would like to highlight our role as pediatricians much before in the precursor days itself, when these children present with developmental delay, and there are some causes which are easily preventable. So in a country like ours, I wish this was interactive, but which other conditions do you think, treatable conditions, that can be ruled out in children with developmental delay? And also, as all the speakers have told us, any other problems that you would like to screen every child with developmental delay for? Maybe we can wait for these answers in the chat box while we go ahead for the next question, the next case. So just in case we are short of time, let me just answer. As the algorithm shows us that other conditions like vitamin B12 deficiency, another very understated cause, and we see it all the time, especially if you're in medical colleges or institutes, you see so many children presenting with vitamin B12 deficiency. And we must remember here again that if these children are picked up late, they may have cognitive deficits which may not be as reversal as when you catch them early. They also may have frontotemporal atrophy on the MRI, etc. And then the cognition, of course, may not be reversible. So simple conditions like hypothyroidism, like vitamin B12 deficiencies, which are potentials for intellectual disability, I think in our role as pediatricians should be caught much early. And as every pediatrician speaker has told us, screen the child for hearing and vision, because hearing and vision can contribute to develop intellectual disabilities, and also it can occur with global developmental delays. In both ways, it is going to help assess the child better and also help optimize the child's development better. Now coming to case 2, you have a 14-month-old child. His birth history was quite significant. He was SGA 1.5 kgs. He has a turbulent NICU stay of 20 days with HIE, neonatal seizures, probably hypoglycemic. And clinically, when you see the child for the first time, you almost see a good evolving cerebral palsy picture. The child is already spastic, showing tone abnormalities, but you also notice on your examination that there's microcephaly with the global developmental delay. Now again, you do the developmental evaluation, and when you're screening the child, it's good to have a good screening tool in your clinics. So it could be anything. For people who are old timers, who are more conversant with DDST, that can be. In our unit, we'd use the Ages and Stages questionnaire, which is a very nice and quick questionnaire that can be used, especially for English-speaking parents. So here the development was below cutoff in communication, gross motor, fine motor, problem solving, personal social. Why I am highlighting this is we take it for granted that it's a sweep piece, right? So then our focus immediately turns only on gross motor. But as you can see, all the domains of development are involved. Then why should our intervention focus only on the motor part? So obviously, when you're talking to the parents about home stimulation, it should encompass all this, whether it is play, whether it is cognition, and you must focus on all this. Now, coming back to the algorithm of the approach to the global developmental delays, which I hope all of you all will go back and read these lovely, simple guidelines. After we've investigated for the treatable causes, as in the first case, now the second part says that abnormal head size or any focal neurological findings, it is more worthwhile doing a neuroimaging. So since this child had microcephaly and tone abnormalities, so neurological findings were present, you go ahead and you do the MRI in addition to your usual workup. So the MRI does show periventricular leukomalacia with white matter loss, with parieto-occipital predominance, which you would agree was expected given the hypoglycemic seizures. Also, the vision also, which is an important aspect of this child then, showed prolonged P100s on the VP, which means that there was some cortical visual dysfunction also present. Hearing was normal. Now, of course, persistence pays. You really work hard with these children and you can make them walkers, much to the delight of the parents and yourselves. I would love to highlight that this last child in the monkey cap, he had multicystic encephalomalacia. It was almost impossible that this child would become a walker, bad CP with cortical visual impairment. But we had this really illiterate mother who said, nahi, aapke books kuch bhi bole, main to isko chala ke rahungi. And really at 5 years, this child did walk independently and it was such a joy. So what I want to say is that let's not restrict ourselves to what our previous knowledge tells us, but let us expand our horizons and let us, persist with the parents and not, make our knowledge or our preconceived notions our limitation. So then, of course, you know that persistence pays and these children can be walkers and they can get good results. But my case does not focus on that. My case focuses on this lovely little lines that I've written. Let us not focus only on walking. The cognitive domain goals we also should be charting. And help the child do the talking, and inclusion in schools early, we should get starting. Because I think in children with cerebral palsy, we are so focused on the motor goals that we are many a times forget to give these children the stimulation they need in the cognitive domain, just assuming, as we had learned years ago in medical school, that they are MRCP. They are not all MRCPs. They are CPs which may or may not have cognitive domain involvement or cognitive delay involvement. So how many children of CP do you think really have intellectual disability? Why do we assume that every child of CP will also be MR? So, as many of the studies tell us that only 1 out of 2 children will have cognitive impairment. That means 50% of our children with cerebral palsy will have normal intelligence. But then if they don't receive the stimulation early in their life, they will go ahead to add to the chunk of intellectual disability. So let's remember this when we see children with cerebral palsy. Now, case 3, an 18-month-old child from a remote area comes to you with delayed development. Of course, again, the parental concerns are usually in the motor domain. The concerns are that the child is not sitting or walking yet. Again, you look at the child. Oh, this has been missed. Okay, so you, of course, immediately, looking at the last part of the algorithm, go on to your genetic diagnosis, which you know in this child by looking that he does appear like a trisomy 21. And yes, it does turn out to be Down syndrome. And then, of course, you can follow up these children. Again, don't think that every Down syndrome is doomed to have intellectual disability. So what can we do for these children? We have very good guidelines and very good follow-up algorithms. In fact, a recent American Academy of Pediatrics, guidelines in Pediatrics 2022 have shown very good follow-up charts, which you can use in your clinics. And I think we are expecting Indian guidelines for follow-up of children of Down syndrome also very soon. So all aspects. So even if a child of Down syndrome is going to have intellectual disability, I am sure we can minimize the impact of that intellectual disability and probably shift from moderate ID to mild ID, which will go a long way in habilitating these children later in life. So please go ahead and work on these children from the beginning and not give up because the child has Down syndrome. And this only the pediatricians can do, because obviously we are the people the child is going to come to for the regular vaccination. Now, of course, the algorithm and the follow-up plan has a lot of things to look at: sleep problems, the hearing, the ENT problems, of course, even along with the medical problems that are associated in Down syndrome. But we are focusing on the cognitive now. Now, case 4, which is usually what we see when we are talking about intellectual disability. Now, this is an 8-year-old child referred from school with concerns of poor scholastic performance. On detailed history, you find that the birth history was not significant. On the fine motor, on the developmental history, you do see that the fine motor and speech were delayed. Socially, also, the child is reported to be shy and takes time to warm up. Ophthalm, normal, hearing, normal. On psychoeducational assessments, which are the assessments we do when a children poses to us for cognitive problems, the IQ done by WISC shows an IQ of 65, which is suggestive of mild intellectual disability, and the social quotient also showed a mild level of deficit. So, again, in this child, we look at the features and we realize that it does indicate a genetic cause. Now here, it turned out to be Fragile X syndrome, which is another most common known inherited cause of intellectual disability. May I request the audience to please mute themselves? And it affects 1 in 5,000 male children. The screening here did show more than 200 CGG repeats.
Excuse me, please. I request the participants to mute cheyandi, please. Please mute cheyandi. Sorry, Dr. Leena, please.
Yeah. So this was suggestive of Fragile X. And so when we evaluate any child, can the host please mute all the participants?
Sure.
So when we evaluate any child with intellectual disability, we know that the chunk of causes are more genetic or chromosomal. Okay, but then of course there are developmental brain abnormalities like lesioncephaly, hydrocephalus. We have inborn errors of metabolism. Very important to spot them early because some of them may be amenable to some treatment. Then we have congenital infections, which all of us are aware of, the TORCH group. We have postnatal causes, perinatal causes, as in, of course, the perinatal history and the prenatal history that all of us focus on. So intellectual disability, as we all know, is a neurodevelopmental disorder with varied etiologies characterized by significant limitations in intellectual functioning, whether it is reasoning, learning, problem solving, but also along with it, adaptive behavior. That is how independent the child is in his life outside school is also important. When I say outside school, I mean outside academics. How do you see a child? Usually in a newborn, you may spot some dysmorphic features. In early infancy, there may be concerns about vision or hearing. In later infancy, you may find some motor delays, later language delays, cognitive delays. We don't spot easily because most pediatricians are not very tuned to looking at cognitive milestones per se. And then school-age children may present with academic or behavioral difficulties. So mainly, you know, that we have the mild, moderate, severe. I will hurry up because I think I'm exhausting my time. The mild forms the major chunk, and they are, you know, earlier used to say that they are educable. So they are not spotted many a times till, you know, a few years of school. They may learn to learn jobs well enough to support themselves or with minimal support. The moderate IDs are trainable, but not very educable. They can take care of themselves, travel to familiar spaces, and learn basic skills. The severe ones, of course, need pervasive support and cannot be independent. The only difference between DSM-4 and DSM-5 is earlier we relied only on IQ, which is actually more indicative of the academic achievement. But now DSM-5 harps on the adaptive living, because that will actually decide how independent the child is in his everyday life. And so they classify it based on how independent the child will be, whether with minimum levels of support, with moderate, like can live in group homes, etc., or will require daily assistance. The diagnosis, as we saw, was through psychoeducational assessments. In global developmental delays, you could do tests like Bailey's or Darcy, but when the child is in the age of intellectual disability, above the age of 6 years, most of the tests used are the Wechsler's intelligence scale for children, along with an adaptive behavior screening, as we said, the VSMS or the Vineland adaptive, because the adaptive component is also very important. Now, these diagnostic testings usually comply very well with the functional levels of the child. Investigations, we've already spoken about the in-depth history, the examination, vision and hearing, the genetic as required, whether it is a karyotype if the diagnosis is staring in your face, or a chromosomal microarray, or nowadays even an exome sequencing if required. Neuroimaging, not in every child because the yield is quite low, but if you have a child who has some focal neurological deficit or microcephaly or macrocephaly, the yield may be worth it. Hypothyroidism we spoke about, lead only if there is environmental exposure. Metabolic testing, when we know that there is a history indicative of a metabolic disorder like consanguinity, sibling deaths, episodic decompensations, or failure to thrive along with, vomiting, etc., which suggests a metabolic cause. So MECP2 we couldn't think about in very female with intellectual disability. Now, the last point is what I want to highlight, that it is necessary to have repeated history and examination, because sometimes in the newborn period or the early infancy, the phenotype may not express itself completely. Treatment, basically it is to the interventions based on the developmental delays that we see. But then, as we said that in IEMs, etc., there may be some underlying cause which would be amenable to treatment. In fact, there's a very interesting site called treatableid.org, which actually gives a clinician interaction to, look at treatable causes or metabolic causes of intellectual disability. Then, of course, you have to treat or manage the comorbid conditions associated, because there'll be ADHD, there'll be behavioral problems, there'll be anxiety, depression, and this will add to the overall picture. So basically, just like all my previous speakers have said, a multidisciplinary management plan along with adaptive training, which is very important, to, help the child feed, have the child have toilet training, accident prevention, when the child is older, some sexuality education. And for this, we need a multidisciplinary team of developmental behavioral pediatrics, neurology, genetics, sometimes psychiatry, and maybe some surgical specialties if there are some congenital anomalies. Now, we may have educational goals as well. So the ones who would be attending PSPP would probably be more tuned to this, because there'll be functional curriculums, life skills also should be taught to these children. Now, all children of ID do not need to attend special schools. The milder ones may be educated in regular schools along with special classes or with support of the resource room. So the extent to which each child should be habilitated in normal schools or special schools depends on that child's strengths and weaknesses. So it cannot be a one shoe size fits all. So let me close by just the key points that intellectual disability is a neurodevelopmental disorder with multiple etiologies. It is characterized by deficits in both intellectual and the adaptive functioning. And that is something we should focus on. It affects approximately 1% of the population. But for pediatricians, my message is don't wait till they go to school. Catch them early at the precursor developmental delay, which may start popping up much earlier than we spot them as intellectual disability. Plan intervention with developmentally appropriate goals. And remember, every GDD will not grow up to become an intellectually disabled child, provided they are intervened early and appropriately. In fact, just yesterday, we had the joy of this global developmental delay with autism, bad behavioral problems, toddler who had come to us. Now she's 6 years plus, and she's one of the few who could actually get good IQ scores now, and it's a joy. So do remember that GDDs are not doomed to be IDs. So intervene properly and try to improve their cognitive outcomes. And that we have highlighted with the first 3 cases, because I don't want pediatricians looking at IDs referred from schools. I want them having, been aware of it much before that and intervene so that we can optimize the outcomes and reduce the impact of the intellectual disability. Thank you.
Yeah, thank you, Dr. Leena Srivastava. Excellent presentation and with good key points. I think we practicing pediatricians should catch children before they enter into school to prevent irreversible intellectual disabilities. It was a wonderful presentation, as expected from an authority. Thank you very much, Dr. Leena. Now we'll move on to the next part of our symposium, that is our panel discussion. This would be moderated by Dr. Suchit Amboliji. Again, I would like to say that he is an advisor to me to organize this symposium. And from day one, I was in touch with him, and he's been guiding me regularly. Thank you, sir. He did his MBBS, then DCH, then PG, DAP, then PGD MLS, and PhD Pediatrics in Developmental Pediatrics. But I'm proud to say that he was the first practicing pediatrician to be honored. PhD.
Okay, I found this on the web for PD, then PGD, Pediatrics in Developmental Pediatrics, but I am proud to say that he was the first practicing pediatrician. Check it out.
I'm sorry, I don't know what it is, but he's the first practicing pediatrician from to be honored by the Maharashtra government, and he did his PhD from Maharashtra University of Health Sciences, and he was the national EB member of Central IAP during 2017 and 2019. He had participated in many international, national, state conferences, and recently he's been there in World Conference of Developmental Pediatrics at Bangkok, Thailand, and he had enjoyed the holiday at Phuket. Over to you, Dr. Suchit, sir. Please introduce your panelists, please.
Thank you, Dr. Bhaskar, sir. Actually, at the outset, I must thank your organization and you for actually giving me this opportunity to be a moderator of this symposium. And I think all the panelists which are there, they are very young. I will introduce them later. Most important thing is that actually I'm actually honored also with the faculties who were there, who gave the lectures before me. So actually, Dr. Samir, then Dr. Jafar, Dr. Leena, and Dr. Pratima. So all were actually all lectures were very good, and they were very useful for the general practitioner. But what is more important nowadays, we are getting problem is regarding the behavioral problem, which is very common. Means I think in our practice, many mothers are asking these questions very commonly, and even in adolescence, we are getting depression and anxiety very commonly. So we have selected all topics which are very important as well as very useful for the pediatricians' point of view and their practice point of view. And actually, behave is to conduct oneself, and behavior is manner or conduct act. The child behavior is actually end result of a wide variety of factors which are operating from before pregnancy, during delivery, and his subsequent environment. The actually here behavioral problems are the result of conflict between his developing personality as well as attitude of his parents, teachers, and peers. Most important is that normal or abnormal is based on the developmental age of the child, because sometimes what we feel is normal may be abnormal at another age. So that is very important. So normal and abnormal based on developmental age of child, depending on personality of individual child, parental responses, and environmental factors is important. Actually, few developmental the behavioral problems, they don't require any treatment except counseling, and counseling is also very important. And there are some steps which a pediatrician gives 2 or 5 minutes, he can manage few cases also. So like thumb sucking or negativism or stammering or bedwetting. So they are very common problems you must be getting in your day-to-day OPD practice also. And then lying, stealing, or some phobias. Here, remember that parents do not pay attention to the needs of the child. Many times this happens. And unless the child shows behavioral changes, negative behavior gets reinforced and such a behavior becomes a habit. So pediatrician has to learn to identify early and try to break this vicious cycle. So when we get our common behavioral problems, we are going to see few of them which are very important, as well as stimulation program. This is very important, that at what age, what toys to be given, what type of environment to be advised. Because we have seen Leena saying that we should identify developmental delay at early age. That is very important. But whenever we identify that, mother will ask you what I should do for that. That is their question, that whether I should go for the stimulation program. So what type of stimulation program, what type of toys. So all this are also very important. So I think with this introduction, I will introduce my faculty who are panelists today. Dr. Dedipya, she has completed her MD Pediatrics and done her IAP Fellowship in Developmental and Behavioral Pediatrics from Sri Ramchandra, Chennai. She is consultant, developmental pediatrician and clinical lead at Fernandez Child Development Center. She is part of team who conducts training program of parents and professionals in various aspects of developmental and behavioral disorders. And she is member of IAP Neurodevelopmental chapter as well as Indo-Canadian Autism Network. Then Dr. Sana Smriti, she is a consultant neurodevelopmental pediatrician, and actually she is practicing as a developmental pediatrician since last 3 years in Hyderabad. And she is a consultant and founder at Begumpet Austere Clinic. And actually her professional interest is that building and advocating the family-centered care and participation based approach. So here it is very important that responsive parenting is very important nowadays, getting by the parents, because parents do ask that what we should do, and we should be able to advise them what their role. Then Dr. Rishikesh, he is very good combination, that he has done DCH also, and he has done MD Psychiatry. And he is currently working as assistant professor in child psychiatry in Nilofer Hospital, which is a very good institute, and conducted workshop on early screening methods in autism, awarded as young speaker from Indian Psychiatric Society from South Zone in 2018. His special areas of interest in child psychiatry, especially in autism, ADHD, and specific learning disorder. He's regular speaker in PG training program as well as webinar, and training medical officer under RBSK as well as NHM program about child psychiatry and POSCO Act. Dr. Shruti Mishra, she's a consultant developmental pediatrician, and she has she's presently attached to Ankur Hospital for Women and Children, and she's attached as assistant professor of to NIEP PID Secunderabad. And her areas of specialization are autism spectrum disorder, ADHD, developmental delay, poor scholastic performance, and high-risk newborn follow-up. So I think with this introduction, we will start with our question. Sorry. So first question to Dr. Dedisya, that my child is 2 years old and she doesn't listen, and she throws tantrum when we do not give what she wants. So how to handle such child?
All right. First of all, thank you for the opportunity. So temper tantrums are generally brief periods of anger or outbursts or aggressive behaviors which we notice in children out of frustration or when their needs are not met. And now we have a scenario where the child is 2 years old and they are not able to take a no from the mother, which is actually developmentally appropriate for a 2-year-old child to not understand why the mother is saying a no. So understanding the scenario as a whole becomes very important in such cases. So why, when are the situations the child is throwing the tantrum? What are the antecedents generally? When is that the child is throwing tantrums? What is the response of the caretaker when the child is throwing the tantrum? What is the behavior exhibited by the child during the episode of the tantrum? And then how is the caregiver also, responding, and what is her temperament? All this becomes very, very important. And getting a little medical history and developmental history also plays a major role, because if a child has any developmental delays or any kind of medical issues, then we need to address that as a whole. So once we get an understanding of all of this, then probably for this child, I think reassurance, as it is developmentally normal for a 2-year-old child to throw tantrums, it's very expected. So helping the mother understand that this is developmentally appropriate, and telling her that, whenever the child is doing any reasonable demand, given immediately. Do not wait for the child to throw a tantrum and then give it, because that kind of reinforces that, okay, whenever I shout or whenever I throw a tantrum, then probably I'll get what I want. Rather than, waiting for a couple of minutes or not ignoring when the child actually wants and giving in later, if you respond immediately, then the child will not probably throw a tantrum. And addressing the preventive causes of tantrums, like if the child is not getting enough attention from the parents, or if the child is actually sleepy, hungry, tired, if you pick up the cues early enough, then probably a lot of times we can kind of prevent all these tantrums in young children. And whenever a child is throwing a tantrum, there is always this thing which we say, stop it, don't do it. The child will not understand. The 2-year-old will never understand when we keep shouting as an adult, like, no, don't do it, no, don't do it. So instead of telling, no, don't do it, try to tell what you expect the child to do. Like, can you come sit, or can you do this? So instead of that, no, 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 always from an adult, explaining what is expected from them becomes easy for a child also to understand. And in a situation when a tantrum is happening, remaining calm from the adult side is always going to help the child. So remaining calm and also being talking in a very neutral tone to the child and telling, instead of being very aggressive or the adult shouting themselves or hitting the child, will give a wrong kind of an understanding that it's okay for me also to be upset or shout and hit when I am feeling upset. So this gives a wrong information to the child. So the adult themselves role modeling in a good way will help alleviate to an extent.
Yeah, very nice. Actually, the most important is that you should use timeout technique, where the thing which they want, if it is possible to give it immediately, and if it is not possible, then say no to them. And actually, all family members should say no. That is important. And whenever baby is throwing tantrum, totally ignore them. And if you ignore them, and when the child becomes normal within 15-20 minutes, then stop. After that, talk normally, which is very important. So I think you have given very nice answer about that. And now I will go to next question. Dr. Sana, actually, my child is always playing. That was the complaint by one of the mother. And she is asking that whether my child is playing is a form of learning, or it's just a play which is occurring there. So what is your opinion that whether the play is a part of learning of the children, or play is they should not allow playing to the children, and they should teach them ABCD only?
Yeah. First of all, thank you, Suchit sir, and I'm really excited to meet the mentors of IAP Neurodevelopmental chapter here in virtual Hyderabad. So, and thanks to Bhaskar sir for making this possible. So, with regards to play, I think most of us are now coming to terms with the fact that play was already existing as a part of all our lives while we were growing up. But nowadays, currently, the scenario has changed a lot with two parents working, and a lot of media coming into the focus, and children having more things to learn in structured ways, like joining classes or joining other academics in order to be able to meet their academic goals or future perspectives. However, there has been a lot of research on play. What is play is actually something that, as per definition, it means it is intrinsically motivated and leads to active engagement of the child and has to be spontaneous. These three words are very important because play comes from the child. It has to be initiated from the child, which means the child enjoys doing it and is actively involved in it. Whatever we are trying to teach through structured activities by testing, by test scores or by exams or all of these, in fact, it has been shown that play impacts learning in a much easier and faster and better ways at different levels, including the molecular level, cellular level, epigenetic level, even behavioral level. So there is evidence which actually means that play reduces stress in children. It reduces the cortisol levels in children. It builds a lot of socio-emotional development. It helps children to learn problem solving, helps children to learn executive skills. All of the conditions that we heard today since last 1.5 hours, all of them are impacted because the social skills are impacted, self-regulation is impacted, learning to solve problems, learning to adjust with peers, learning to cognitive skills. All of this have there is a lot of learning through play. And play does not mean play can be through objects, play can be through people, play can be through pretend play. Play can be just rough and tumble play, outdoor play, indoor play, all of this. But here the important thing is it has to be initiated by the child. So I think nowadays it's become a time where we have to prescribe play for a lot of parents in the pediatric OPDs. And we have come to such a state, sadly, because people have forgotten to give the 2 hours of free play time for children where they initiate and do what they are. Play provides an also opportunity. The biggest benefit is for parents because they just interact with their child and start to discover their own childhood and their own, they start having fun, and it's a place of relaxation for parents as well, I think. So 100% we need to encourage play.
Yeah, thank you very much. And actually, here we must remember that we just know the name of Maria Montessori, but we do not know that she has introduced that autocorrective play. So autocorrective toys. So actually, the toys are such that whenever that child plays with the toy, he learns some skill or other skills. So that is very important. So it is very important that play should be used as a learning method, and play is very important for the children below 5 years of age, especially. So now next question I will ask, Dr. Rushikesh. regarding what is difference between normal and abnormal behavior at various age, and is some behavior which may be normal at some age can be called as abnormal at another age. Dr. Rishikesh, please. Hello.
Hello. Am I audible, sir?
Yeah.
Thank you for the opportunity, and thank you, Bhaskar sir, for giving this opportunity. And as per the question about the normal and abnormal behaviors of a particular age, definitely, as the previous question told about temper tantrums, which was behaviorally normal for that age group. And if the tantrum is thrown at around 5 or 6 years of age,
hello?
the same with hello.
Yeah, you can continue.
Yeah. Okay, basically we classify based on, there is a classification called Jean Piaget's classification, which tells you the cognitive development of the child, where the child's ability to understand, which is the environment, the parents, as well as the child's behavior itself. So it depends upon 3 things: the child's behavior, the environment, as well as the parents, how the parents treat the child. So based on that, the behaviors are normal or abnormal will be in this particular situation, whether the child can be adapted or not. So at different age group, there can be a different behavior problems. If the child is of 2 years of age, where the tantrum is thrown, which is completely normal. If 6 years old, 6 years age child is throwing a tantrum, then it is called abnormal behavior. Like this, there are different behaviors at different age group, and it's based on the classification which is given by Piaget's, where the 0 to 2 is sensory motor development, 2 to 5 years is this concrete motor and formal operational motor thinking, where it is developmentally, cognitively normal. Based on that, you can actually decide which is normal, which is abnormal behavior.
Yes, thank you very much. Now, Dr. Shruti, actually, what are pre-reading and pre-writing skills in children, and how we can diagnose learning disorder? Here, I just want to make one note that many times it happens that actually I had one mother last week only. She came to me and she asked me, my child is not writing at all. So I thought that she must be referring to the child who is at home and must be some 6 years old child. But she was referring to the child who was 2.5 years old with me. And she told that now she's going to school and they give homework to the 3 years old child or 2.5 years old child, and she's not able to write. So I'm worried. So is it okay for giving this writing at this age? So what are the pre-reading skill? What are the pre-writing skill? And how we can diagnose learning disorder? Please, Dr. Shruti.
Good afternoon, everyone. So coming to the question, definitely, unless we have a very strong foundation, the building cannot be a stronger one. So when talking about the pre-reading and pre-writing skills, so we say that the initial years of the preschool, the child should first learn how to read. Then only they will be able to later on read how to learn things well in the later ages of life. So first and foremost thing is, in the initial years, the child will be learning the basic pre-reading skills. So when we are actually reading something, we are matching. So the child learns to match patterns. The child learns to match the pattern with the sounds, that is known as phoneme awareness. Again, the child who is good at rhyming skills, like the child understands rhymes a lot, has a age appropriate language skill. The child involves in general conversations of the family. The child enjoys reading, stories being read to him. That means his comprehension is at age appropriate levels. So these children will go on to have a good, these are the prerequisite for a pre-reading readiness. And when talking about the pre-writing skills, writing is a very complex feature. So it definitely involves the child needs to have a good motor stability in the form of having a good posture. The child should know the difference, understand that he can use both the hands simultaneously, like for example, holding the paper pen with the one hand and the second hand can be used to stabilize the paper. Secondly, going on to the fine motor skills, in which the child should be able to have a good grip first. The child should be able to know the use of finger isolations, how to put pressure over the paper and all. Then third thing is understanding the directional skills, or the cognitive skills, what we call it. So the child should first know that what is left side of the page, what is right side of page, memory leading to print awareness. So this particular letter is associated with the sound of P. So for that understanding should be there. And finally, sequencing, how to turn pages and all. So all these, and definitely a very important is visual-motor coordination. So first, if the child has all these skills, then only he can proceed to a further stage of writing and reading. And coming to the question is, how early can we diagnose a learning disorder? To give a formal diagnosis of learning disorder, so as the child enters formal school, we can give a formal diagnosis. Ideally, IAP says that every child should be screened at least for the learning difficulties at 7 years of age. But as we are talking about pre-reading and pre-writing skills, so the kids who are at risk, specifically the child who are showing these symptoms of not being having these skills of pre-reading and pre-writing, and plus the kids who are like high-risk newborn, those who have specific language impairment, autism spectrum disorder, they should definitely be screened and evaluated for learning disorders.
Yes, thank you very much. Actually, it is very important to know that learning disorder can be diagnosed at as early as 7 years of age. And the second thing is that pre-writing and pre-reading skill, if they are there, then only you can advise about writing and reading. Because even at 6 years, if child doesn't write, parents should not be worried, because that child can write afterwards, start writing afterwards, and he can become normal also. So that actually advice should be given to the parent by the pediatrician. My next question is to Dr. Rishikesh, that what are the factors influencing child's behavior? Rishikesh.
Yes, sir. As we come to the question, there are different factors. Basically, it's a biopsychosocial model, which involves genetics as well as the psychology of the child, and also an environment where he's grown. Basically, the parent styles and the environment, the school, that if coming to the teenagers, it's the friends which are coming around. And there are different factors at home. If there are family conflicts, there may be behavior problems in the children. In the child itself, the child has inherent problem of intellectual disability, autism, any neurodivergent disorder like ADHD, or even SLD, or any psychiatric disorders which can present as early as 7 years old, like anxiety and depression, can present with different behavior problems. So based on the environment, based on the child itself, and as well as the surrounding things where he is brought up, and as well as the school, these are the three different things which usually affect the child's behavior. And we have to understand all these three domains and get history from all these three domains to understand why the child is behaving in a particular manner. This helps to understand why and how to treat the child also.
Yeah. Thank you very much. I think this is very important, that all three settings should be asked for, and what are the problems in that, and then child behavior should be assessed according to that. And that is very simple thing, that what may suppose some cases of school phobia, or some cases, so that they just required only counseling, and they don't require any medical intervention. So many behavioral problems, if you properly diagnose at earliest stage, then we can manage them. Dr. Sana, I just want to ask you regarding what is responsive parenting, because all these are very important and they are related to parenting only. So can you tell me about responsive parenting?
Yes, so basically, responsive parenting is now a part of the nurturing care framework of WHO, UNICEF also, where there are other components along with this, like nutrition, taking care of having a good health. And responsive parenting is one of the components that will help in promoting early childhood development. It has 3 points when we talk about responsive parenting. One is it is always child-led. So responsive parenting means observe what the child or the baby is doing, understand why that is happening, and then act on that. This is what it means. So when, for example, if there is a baby who has just turned their head while eating, that which gives us a signal that, okay, my tummy is full, or I've had enough, or I don't like it. Understanding that the baby is had enough, or the baby doesn't want food, and then stopping the feeding process forms a triangle of responsive feeding. Whereas and this forms a lot basis for building attachments in early infancy and early childhood. responsive parenting principles can be used in other ages also, including teenagehood and 6 to below teenagehood older children, wherein you're understanding what the child is doing, interpreting it, and then responding to that in a meaningful way and in a very joyful way. It happens in a framework of a nurture and interaction that is has a positive environment around it.
Yeah, it's very, very nice. Actually, it is very important nowadays to know the responsive parenting, and we should tell the parents regarding that, what are the areas like nutrition, development, whatever the things she was telling. And here we have actually with IAP few years back, we have prepared one vaccination card where physical vaccine as well as emotional vaccine was introduced. And so if we explain them when they come for physical vaccine, what are the emotional things to be taken care of, and what are the how you can increase EQ of your child, and that is definitely, it's very helpful, which I found in my practice. Then next thing is regarding that we'll go for the management of the all problems now. So Dr. Dedipya, I just want to ask you regarding what is the management of thumb sucking and habit disorder. Here I just want all panelists to tell the management which can be told by the pediatrician to their parents. Can you highlight about management of
All right.
thumb sucking?
Yeah, so habit disorders are nothing but like anything which becomes a habit and we do repeatedly, we call it as a habit disorder. The thumb sucking is one of the most common, I think, habit disorders which we come across. And it's very common in infancy because it has a very self-soothing and comforting response when the child puts the thumb in the mouth. But when it continues beyond a certain stage, that's when it becomes a problem. It's a self-seizing behavior around 2 to 4 years. Generally, the child tends to stop it. But if it continues for a prolonged period, then it does have sequelae as well in the form of blisters or hyperkeratosis, and you can even have malalignment of the teeth, anterior bite. So some of the complications will be there. But understanding a little in depth about thumb sucking again will help us, in giving the right kind of management. Because generally, if the child is doing prolonging it for a long time, we either try to scold the child or put some neem paste and stop these behaviors. But understanding at what age the child actually started doing this thumb sucking, what is the frequency, what is the intensity with which the child is doing becomes very important. It's because it was also related to the psycho-emotional maturity of the child, if they're going through any separation anxiety, if they're having any underlying family disturbances. So because a lot of times emotional component plays a big role in this behavior. Apart from this, the oromotor structures also is something which we need to look at. So generally the tongue, which has to be in the resting position, if it is not in the resting position, the child feels a little uncomfortable and tries to compensate by putting the thumb in place of the tongue to get that feel-good response. So looking at whether the child is having good sleeping habits, whether the child is having oral breathing instead of nasal breathing during the night time, and whether the child is actually continuing to eat mashed foods. So all of this also becomes very important part, because if the oromotor structures are not developed well enough, also the child would continue to do thumb sucking for a prolonged period. And management totally depends on what the situation is. So behavior management strategies like positive reinforcement, all of that can be done. And myofunctional therapy, especially if the oromotor functioning is not good, then the myofunctional therapy, some dental appliances also can be provided. And if it is prolonging for a very long period, like more than 4 years of age, then definitely a dental opinion is also advised.
Yes, thank you very much. Actually, here we should remember that thumb sucking, when it starts, actually there are at 6 months of age, it is very normal that child sucks thumb. At 1 year also, as she has told, that it may be normal. But after that, if it becomes a habit, how it can become a habit? there are 4 or 5 reasons that are very important. That child may be hungry, then child may be having insecure feeling, and that is very important. That actually here most important thing is that mother take care of hunger, but she doesn't take care of the what is the emotional part of that child. Because when child feels secure after sucking thumb, child will go on sucking thumb. Because when child is alone, child will suck the thumb. Child will suck the thumb at the time of night, where child wants to sleep and have actually mother's skin touch, which is very important. So such things also should be kept in mind, and then according to that we should ask the mother to manage that thumb sucking. Other habit disorders are there, and actually we will not able to discuss the management here due to time lag, but we'll try some other day. Dr. Sana, I want you to highlight about the management of nocturnal enuresis, which is again a very common problem. When to start the treatment? That is a big question, because many parents want even at 2 years or 3 years also. So when to start the treatment, how to advise them, and what is the line of treatment we should give to the parents, please?
So ideally, a child who is of 7 years or older than that, even developmentally, or either developmentally or chronologically, it may be a good time to start thinking about the treatment of nocturnal enuresis, because after 5 years, most of the children start having control over their bladder during the night also. However, if there can be many reasons for nocturnal enuresis, and sometimes it can be secondary. That is, after the child has already achieved good control in the night, and there's a considerable amount of time that has passed, and again the child is showing signs of nocturnal enuresis at any age. That is something that you must also consider to evaluate. Management, like especially if there is a gap of 6 months or more after the child has been completely free of bedwetting in the night. So nocturnal enuresis can have both medical causes as well as non-medical causes. Medically, there can be developmentally, there can be a delay in the maturity, but along with that, there can be neurological issues, epilepsies, constipation, and snoring, and spinal cord issues. All of this can add to nocturnal lead to nocturnal enuresis. So this history has to be taken, I think, to begin with in a proper way, whether it is primary, whether it is secondary, and whether any comorbidities are there, or if along with the bedwetting, is there daytime also there is incontinence, how is the bowel movements, all of these things. And also to check if there is a change in the psychosocial environment of the child, like sometimes stress or undue pressure on the child, or something that happened in the school, some sort of abuse. All of these things can also lead to such symptoms. And so history again forms very important here to understand what could be the reasons. A lot of times it can be just functional or genetic, where one of the parents would have been having a delay in maturation of the bladder capacity, or excessive production of urine, or the bladder overflow may be happening, contraction, detrusor contraction may be affected. With disregard to any of the reasons, one of the most important things that pediatricians can advise the parents in the OPD is that it is not voluntary. Children do not do this voluntarily, and to avoid any sort of negative comments or punishment or while this is happening, because that can change a lot and it will just delay the process of controlling. So if this one thing is told in 1, 2, or 3 sessions also, it makes a huge difference for the child. And also giving the explanation about why this is happening and what are the causes, telling that to the parents, spending time and telling that to the parents makes it easier for the parents to understand. And then they will stop blaming the child for it, which makes a huge difference. Of course, there are other treatments depending on the cause, and but parent education forms the basis. Later on, alarms are there, and if that doesn't work, medications for older children are available.
Yes, thank you very much. I think I will ask Dr. Rushikesh regarding that nocturnal enuresis, whether you considered it as a sleep disorder, or you can manage according to the thing Dr. Sana has told?
Sir, as Sana Smriti has told, basically evaluating the reason is very important. Why it started, what is the whether it is primary or secondary enuresis. If it is secondary enuresis, then all the organics will be most of the times will be put aside. It is mostly because of secondary emotional problems, or recent history of any trauma, or recent loss of family members, any emotional abuse to the child, or any family conflicts. And here treatment differs very differently from the primary enuresis.
Here
and madam, I
would
differ from one point from Sanasprati. The definition itself says that it's a voluntary or involuntary voiding of urine is enuresis. In case of opposite defiant disorders, there may be voluntary voiding of urine. I have seen cases where child does voluntarily void the urine to irritate the parents because parents are not accepting his demands. In those cases, there can be a voluntary enuresis. That is the definition itself says. So it's not always involuntary. It can be voluntary sometimes also. So as the child grows older, medication plays along with therapies. Not only therapies, medication also with therapies will play a major role in treating the child.
And regarding sleep disorder?
And in sleep disorders, if it is happening in a particular period of time, we have to note most of the enuresis are not regarding based on the sleep disorders, sir. It is only enuresis which presents. If there are sleep disorders, there are particular categorization of sleep disorders are there. In those cases, there is no enuresis noted in the diagnostic criteria anywhere, especially in those sleep disorders which are mentioned. So we have to differentiate from sleep disorders, but enuresis has to be addressed primarily before sleep disorders have to be understood properly.
Yeah, thank you very much. Now, I will go to Dr. Dedipya for regarding how stimulation programs helps in development of children.
Right. So I think with advanced perinatal care and improved chances of survival in the newborns, it's also become very important to nurture these little ones appropriately and in the right way. So as we all know about neuroplasticity and what remarkable capacity these babies have to absorb and adapt to situations when they are young. So I think we need to grab that time to provide the right kind of stimulation to the babies. And because whatever stimulation they receive during the early years is directly proportional to the number of synapses, the quality of synapses formed, which determines their architecture of the brain to set the stage for future. So as we all know, high-risk newborn needs to be followed up very regularly, and we need to pick up if there are any issues and address and stimulate them accordingly. But it's not just about the high-risk newborns, but also high-risk babies in general. For example, there is a family where the one sibling already had a developmental disorder. Then it becomes all the more important for the other child, because he can't wait till the child grows up and sees if he demonstrate any signs or symptoms. We need to see what kind of stimulation has to be given to this child from the beginning, so that, you can kind of evaluate these issues to a large extent. So we can choose any kind of stimulation programs. There are a lot of programs available. One model which is very well designed and evidence-based from Dr. M.K.C. Nair, I think it's a very good program to do once the high-risk newborn follow-up is done. And also the developmental program, whatever we choose to take, the stimulation, what we choose to take should be in the zone of proximal development of the child. The activities have to be age appropriate and at the level of the child. We need to make sure that it also happens in the naturalistic settings, not just in a room or in a therapy room, and the right kind of toys or materials to be given. And quality is always important over quality when we give the stimulation. And in all of this, parent plays a huge, huge role in the way the child shapes up. Also, if we are doing DDST screener or ASQ, I think the screener also has activities, or as to what kind of activities you can give if the child is failing in any item. So I think we can adapt to whatever is suitable for our setup and start giving stimulation activities for the babies.
Yeah, very nice. The most important thing is that we should now start subscribing. Actually, we should prescribe the stimulation program at birth. So maybe Trivandrum Bal Vikas program, which is one of the important program, and also Portage Education, which is by Dr. Tehel Kohli from Chandigarh. Department of Education. She has prepared a very nice program. Nowadays, Portage education is used in more than 90 countries. And Hindi version is available with Dr. Tehel Kohli's Savan Pradarshika, she has published, which is a very nice program where suppose दो शब्दों का वाक्य बनाना, आपने क्या करना है 1 2 3 4 5 and सहायक खेल सामग्री. So actually like this, they have divided all this gross motor, fine motor, expressive language, receptive language, and mental development. All they have divided, and every area, suppose language development, there is from 0 to 6 years, it is around 140 items are given. So that is very important, and age also has been given for every item. So that should be the advice to be given to the parents. Now, Dr. Shruti, I just want to highlight regarding the management of learning disorder to the parents as well as some part of the teachers, because many times parents also ask that what we should tell to the teacher, because that is also their question. So can you give advice regarding office management about learning disorder?
Definitely. So first thing is, when the parents come to us, the pediatricians, with the concerns of learning issue or any learning disability, or if any difficulties, I would say. So first thing is, we have to tell the parent that the child, which is known as demystification, that the child is not doing it purposely. It is not because the child is lazy or because the child is like throwing some kind of tantrums that he is doing it. First thing is that. Second thing is, we can actually, like with respect to the parents, first thing is, we as a pediatrician is, we have to rule out whether it's a actually specific learning disability that we are dealing with, or it is a learning difficulties, because these two things are different. Poor scholastic performance or academic performance may be because of variety of reasons. First thing, as a pediatrician, we have to see whether the child has been screened for hearing and vision, which is very, very important. A basic evaluations in the form of thyroid evaluation, normal iron profile we can do at our office management, and going on to a detailed history. When did this start? Does the child have any chronic illnesses that is predisposing to this? Associated comorbidities, any behavioral issues that can be there should be addressed definitely. For the parents, and definitely specific learning disability, we have to go in for the diagnosis, we have to go in for a complete psychoeducational evaluation. But sometimes if it is not possible on an immediate basis, because we don't have that approach in our city or smaller town or rural areas, we can at least guide the parents, looking at the previous records, looking at the books of the child and all, what kind of pattern the child is showing the problem in, which language is very specifically difficult for him or her to be coping up with. And then accordingly, for parents at home, generally the treatment we do advise is remedial education depending upon the child's level. So few aspects of that actually should be practiced at home also by parents. Suppose starting like whenever the child one-to-one teaching should be done, it should not be a group session. We have seen that in one-to-one teaching, the child does better. Second thing is revising the previous sessions that has been done every time. The child should be specifically told what is he going to learn in the current session, what all activities or what all instrument does he require. Does he require color? Does he require pen? So that the child is not haywired completely. For a group teaching and providing basically specific postures and all, because we have been talking about pre-reading and pre-writing. So the child should be seated on a table. They can give a small footstool to make the proper posturing, so that when the child is writing, the grip is proper, and we can work on that. Few activities related to visuomotor coordination can be taught to the parents, like using beads and all, a lot of dough and clay activities to strengthen the grip. And for the teachers, actually either in the form of a letter, because we as a pediatrician are advocate for the children. So we can give a letter with instruction to the teachers, or we can have a meeting along with the parents in which we are specifying, we can actually advise the teachers to make a preferential seating in the classroom so that the child does not get distracted away. If the child should be specifically stated that if he has any queries and all, he should raise his hand instead of just disturbing the classes and talking others. So, and few concessions are also available in the national boards and in various states also. So for example, there is some 1 hour or 25% extra time given, some grace marks can be given. spelling errors and punctuation marks are ignored for a child with dyslexia. So same things can be followed by the teachers at the school. The knowledge can be tested orally rather than focusing very much on the spelling and punctuations in the initial time when the child is actually coping up with these difficulties and all. And definitely this strengthening the strength is what is important, because now we talk about multiple intelligence. It is not only academic. So always, if the child is good at painting, if the child is good at singing, those should be encouraged for a proper building of self-esteem.
Very nice, very nice and elaborate. Actually, you have told. The most important thing I want to add is that regarding 2016 Divyang Act, which is very important, and it should be known to all pediatricians, because previously learning disorder facilities which were there for the board only, means 10th examination or 12th examination. But nowadays, with this act, all the facilities which are there, like extending the time or giving assistance or giving writer, all these are given from first standard till graduation. So this is a new correction which has been done in the law. And most important is that in that law, previously we used to have only 9 disabilities. Now it is 27 disabilities which has been defined, and that has been given concessions, which is very important, because even intellectual disability, Lina was referring. Before that, actually, all these scholastic backwardness more commonly seen in cases of 70 to 90 IQ, which is very important. These are slow learner, and this slow learner also get some benefit which has been identified by the law now, because before 2016 slow learner were not identified, and now they are identified and they get help, and they are more in number. So now we'll come to the last question of our discussion. Dr. Rushikesh, as we are running short of time, can you just highlight regarding how to manage, because how to do the screening for this depression and anxiety, and at what level pediatricians manage, and when they should refer to psychiatrists?
So basically, understanding depression and anxiety for children is pretty difficult, sir. And they should have the cognitive ability to understand either anxiety or depression. The child should understand first what is wrong with him, then he has to express it. So about 2 years of age, children will be able to understand what can be wrong, and you talk directly to them. They'll tell the complaints that I'm feeling fearful, I'm feeling anxious, I'm feeling low, I'm unable to cope up with things, I'm not able to concentrate. All these complaints will be told by the elders. But between 6 to 12 years, the child is presenting very early, then the child will not be able to understand what is wrong with him, whether in anxiety or depression. So they usually present with multiple somatic complaints like repeated pain abdomens, some present with repeated vomitings, giddiness episodes, or increased heart rate, school refusal. All these things can be a part of a domain like anxiety or depression. So we have to understand what exactly is wrong with the child. We have to sit with the child, take the history in different domains, whether any particular stressor is causing, or it is onset is de novo, and there is any family history of anxiety or depression. We should understand that. And coming to the management of these children, between 6 to 12 years, we have to understand the presentation of depression is very, it presents with atypical manner with increased sleep, excessive eating, and irritability rather than low mood or decreased concentration, and excessive temper tantrums will be increasing, and there will be recent change of onset of behavior. This is a particular point which have been noted. Child was fine previously, but there is recent change of onset of behavior is noted. So when these particular symptoms are present, then we have to grade whether it is mild, moderate, or severe. Based on that, we have to plan a treatment. If the symptoms are very mild, then repeated addressing the parents, how to manage the child at home, how to address the child, not like telling negative comments about the child. And usually parents, what they do, or even people around them, they do, it's very, very common. We went through it. Why can't you go through it? We are providing everything to you. Why can't you deal with those things? All these things will be told to the children, but children won't be able to understand at that level. So understanding the child and repeatedly addressing the parents about the issue will help in mild cases. But in moderate to severe cases, you have to definitely start on pharmacotherapy along with addressing the parents, and parent education is very important. And about the school things also. But most of the complaints, what I see in Nilofer are referred to me are physical complaints rather than the psychological complaints like vomitings, pain abdomen, giddiness episodes, repeated headaches. When a pediatrician is coming across and every investigation is normal and child is having repeatedly complaints, then you have to think of any psychological problems existing with the child or not. It can be anxiety or depression or any other simple problems like learning difficulties. All this can present at this age. Between 6 to 12 years, it is very difficult to diagnose, and we have to address all the issues, take history completely so that to understand. And management will only restrict to counseling to the parents rather than the child itself. Understanding the child and tell him not to worry will not help easily, that much easily. Understanding what the child is going through between 6 to 12 is very important. And more than 12 years, child itself can say what is wrong with him, because he understands what can be wrong, and he can express things directly when you ask him. So this is overall management. Rather than going too deep, we can understand the child, and pediatrician can manage up to the level of mild depression, mild anxiety or mild depression.
Yeah. Thank you very much. Actually, here just I want to add few things that we can remember one sentence, that this world with depression crying. And with that sentence also you can see the symptoms of the depression. So mood, interest, sleep, weight, that is decreased appetite, worthlessness and guilt, death wish or act, energy, fatigue or libido, and psychomotor activity which may be slowing, and concentration or decreased memory. So out of these 9, if 5 are there, then definitely we should for more than 2 weeks, then we should suspect depression, and we should give them Beck's depression inventory, and for the scared test for the anxiety, so that we can at least come to know what is the problem. And then, as he told, that mild depression and mild anxiety we can manage, and if it is more than that, moderate or severe, then we should take opinion of the psychiatrist. I think with this note, we are at the end of the symposium, and I'm very grateful to Dr. Bhaskar for giving this opportunity to present this symposium amongst you. And I was very happy with the enthusiasm as well as answers which were given by the young brigade, which is from Hyderabad, and it shows that there is a very bright future for Hyderabad developmental and behavioral pediatrics. So I congratulate all of them, Dr. Dedipya as well as Dr. Sana, Dr. Shruti, and Dr. Rishikesh for joining with me for this symposium. And thank you very much for that. Thanks a lot.
Thank you very much, sir. Thank you, everyone.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you. I think it's over to the organizers for Bhaskar sir. Bhaskar sir.
Yeah. Thank you, Dr. Sujit.
Yes, sir.
For organizing the panelist discussion so well. And I would like to tell to the participants that this is not a pre-texted or pre-scripted panel discussion. It was a spontaneous question and answers type panel discussion. Thank you, Dr. Sujit Ji, for your masterly moderating the session. And I'm sure you must be very much impressed by our rising stars from Hyderabad.
Yes, definitely.
Up to your satisfaction. Yeah. And they are the torch bearers of developmental pediatrics for Hyderabad and Telangana. My special thanks to you and to the panelists, Dr. Rishikesh, Dr. Dedipya, Dr. Shruti, Dr. Sana, and also all the faculty members who have participated in this. And my special thanks, sincere thanks to the participants, without whose encouragement, without whose presence, we the organizers cannot organize these kind of symposia. And even the faculty members will have more enthusiasm if people like you participate in this program. So once again, on behalf of entire IAP Twin Cities branch, We sincerely thank all the faculty members and as well moderator and the panelists of the panel, and also the participants for making this symposium very meaningful, informative, and educative. With these few words, I thank you all and hope to see you again. Thank you, sirs.
Thank you very much, sir. Thank you.
Thank you very much.
Thank you.